फादर का सैंपल अभी नेक्स्ट रन में गया है, तो उसको हम लोग को वेट करना पड़ेगा, ठीक है, फादर का रिपोर्ट आने तक, बिकॉज दोनों ही मोस्ट प्रोबेबली, अगर फादर में पॉजिटिव आ जाएगा तो दोनों को ही इधर बुलाना पड़ेगा, और तब तक हम पीएम से भी पूछ लेते हैं कि क्या करेंगे हम लोग। ड्राइवर बात करके तो रखिए, वो गाड़ी सैनिटाइज होगा, मोस्ट प्रोबेबली वो ड्राइवर भी उसको भी देखना पड़ेगा, ठीक है। हाँ 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 हाँ, मुझे लगता है स्थिति आ रहा है, इसलिए हम लोग के पास नहीं जा पा रहे।
Madam. Hello, Dr. Mangla. You are muted. You are muted.
Okay, now
I could understand you were talking, but couldn't hear you.
now mute here.
Yes, yes.
Yeah. Okay. So yesterday I couldn't log in onto my laptop, no. So today I'm okay.
Okay. And how are you doing?
Yeah, great.
And great initiative.
Yes.
Great initiative. Lot of hard work.
Do you recognize me?
She recognizes. She was trying to get an opportunity to peep in. I said, no, this is too formal. You can't say hello.
No. It reaches immediately like. Yesterday I was on mobile. No, I didn't understand much because I was not seeing anything as a whole.
Oh.
And but now today I could. I came early and with Vishal I could get inside. You know. So it was great session yesterday. Apart from this login difficulty, but hopefully today there will be more people able to come inside. Hello, Dr. Prashant. Prashant is needs.
Yeah. Connect. Also.
You need to unmute.
Okay, hello.
Yes, can you hear now?
Yes.
Great.
Good afternoon, Dr.
Good afternoon.
Prashant.
Hello, how are you? You spoke well, Shebani madam, yesterday.
No, thank you so much. Please call me Shebunti. No, madam, nothing, sir. Just Shebunti is fine.
Okay, provided you call me Prashant, then I will call you Shebanti.
Yes, yes.
Hi, Manisha.
हाय हॅलो मॅडम
कशी आहेस?
बस बरी तुम्हाला ऐकू येते
हो.
हा ओके I am hearing some echo. I don't know whether it is from someone else or from my computer. I don't know.
I have another phone which is on, but I have to turn it off, I think.
Okay.
Hi, Manisha.
Hello. Mangala, madam. Good evening.
Hello.
Hello.
Yes, how are you?
Yes, fine, madam.
Hey,
Sir, पुण्याला? Hello. पुणा कसा काय म्हणतो पुणा?
Sorry?
पुणा काय म्हणतो म्हटलं?
पुणा मस्त आहे. आपल्या
पुणे तेथे काय उणे?
Yes, sir. That is very, very right.
आपल्या सगळ्यांची कृपा आशीर्वाद सगळं चांगलं चालू आहे.
पण आतापर्यंत आम्ही ग्रीन झोन मध्ये होतो चंद्रपूर, पण आता जसं जसं लॉकडाऊन उघडतंय वी आर गेटिंग पॉझिटिव्ह पेशंट. म्हणजे ते पेशंट आता रुरल एरियाज मध्ये वाढतील.
या जास्तच होणार आहे ते.
येस येस.
I'm just checking my presentation whether it's coming onto the screen.
Oh, yeah. You just press the share screen.
Yeah. I'll just open it in the background.
So you got the presentation done, thank God.
Yeah.
Hi Dipti.
Hi, madam.
Kashi is?
बस मस्त एकदम.
Yesterday evening, Vishal told me you were checking your presentation and all.
Yes.
You are at home?
I'm at home.
And sir also?
Sir is also at home. Yes.
I'll just share my screen.
Yeah. Manisha, you have checked, na?
Yes.
Manisha Gogri. There are two
Yes.
Manishas here.
Is this visible now?
Yes.
Yes.
Okay, I'll just make it full screen and see where it goes full screen also.
Okay.
Yeah.
So Dipti Shah has two presentations today. Wow.
No. Okay.
Sorry.
Madam, me bandola hai presentation. I have made it.
Yes, that's good.
सर ने बहुत इस पे काम किया है. मैंने सिर्फ 2-3 स्लाइड दिए रहेंगे बस.
तो पहले तो बोल रहे थे कि नहीं मैं ऐसे ही बोलूंगा. मैंने बोला at least 10.
Are you able to see it full screen now?
Yeah.
Yes, sir.
Okay,
We are
fine.
able to see.
So I'll just stop sharing.
Yeah.
Okay, fine. Yeah.
So
I will remove my video also and mute myself also.
Yes. Let me share my also now since
Yes.
people are there.
Good afternoon once again. Sorry, I had to leave in between for some urgent work. So whenever you say, I'll start sharing my video.
Just wait. I'm just.
Yeah, sure.
Is it visible?
Yes.
Yes, ma'am.
Yeah.
Yes, Mangala, ma'am.
Yeah. That's
Yes, ma'am.
Okay. So I'll stop sharing. Wait, I will just go back. So I don't know how to do that now.
Yes, now it's okay, madam.
No, but I didn't come. Just wait.
मी माझं पण चेक करू का एकदा?
हो सगळ्यांनी करा.
सगळ्यांनी करा.
दिसतंय का?
Yes.
Is it full screen?
Yes, full screen.
Yeah.
Okay, perfect.
Even I will also check. Yeah, you can see.
No. Yes.
Yes, now it is.
No.
Yes.
Yes, na.
We can hear
Okay.
you.
Yes.
रिंकू, हाँ रिंकू,
Yes.
ये हम जीएम से बात की, जीएम तो बोल रहे हैं कि बाकी को शिफ्ट कराओ जल्दी से.
So good.
और
We got
father
already
का आएगा जल्दी
21
से.
participants. That's great.
Yes.
नहीं डिटेल और क्या चाहिए?
मैम डॉक्टर पीके शाह
नाम और एमआर नंबर.
what is his first name? Because there are
So
three
if I have, I will SMS you.
as attendee. One Punita Shah, Pooja Shah. So it's not them, no? Am I audible, ma'am?
Yes.
What is the full name of Dr. P.K. Shah? Because I mean, he's also supposed to be as panelist for today.
Yeah, I have called. He said he's coming at 3:30, but he will come. I have been in touch with him this morning.
Okay. Because when there are three Shah, I mean, whose name I can see as the attendee. I was wondering, I mean, if he has joined as attendee. That's why I was thinking.
No, Dr. P.K. Shah is.
No. So the name starts with P and ends with Shah.
Yesterday he was there.
Okay. Then he will be joining as panelist.
But he was not speaking yesterday, so I don't know in what way he.
रिंकू व्हाट्सएप चेक करो, उसमें एमआर नंबर है. Yes. Okay.
Hi Mangala.
Hi Parag. कुठेस
I'm
तू?
fine.
Yes, मला. Okay. Yes. तुला अजून एक सेशन आहे म्हणत होतास ना आज की नाहीये ना?
नाही माझं झालं ऑलरेडी.
ओके वंडरफुल.
हाय मंगला, मी आगरखेडकर.
हॅलो सर, कुठे आहात तुम्ही? येस, तुम्ही तुमचा व्हिडिओ हे करा.
हो येस.
म्हणजे आम्हाला दिसाल तुम्ही. येस. कसे आहात सर तुम्ही?
मजेत एकदम झकास.
हॅलो डॉक्टर आगरखेडकर, कसे आहात?
नमस्कार. नमस्कार पराग.
हॉस्पिटलमध्ये एक पण कोविड पेशंट नाहीये ना?
येत आहेत ना, आम्ही पाठवतोय ICM-ला. येत आहेत, डिटेक्ट होत आहेत. 2-3 येत आहेत.
ओके. मेघ मॅडम अजून आल्या नाहीयेत पराग. येतील.
She is not supposed to be chairing today, na? Kal she was to chair yesterday.
She is not chairing today, but I think because it is a certification course, probably she will be here.
I don't know. She hasn't messaged me anything. But we have past president of FOGSI ICOG, Dr. P.K. Shah, already with us.
Yeah.
So we have some senior person already.
Hello, Dr. Shah. How are you? I'm Prashant.
He has to unmute.
PK unmute kara.
Yes,
Hello, sir. How are you?
I'm good. Thank you. How about you?
I'm fine. Thank you.
जेवण झालं का?
जेवण दुपारचं घेतच नाही. घ्यायला वेळच मिळत नाही. जे येईल समोर ते मग.
Good afternoon, Dr. Shah. This is Dr. Sudhir Mishra.
Shah sir, कशा आहात तुम्ही? Good afternoon, sir. Shah sir.
Oh, Mangala. Good afternoon.
कुठे मॅडम? गुड आफ्टरनून.
Where is Kuthi?
आहेत का कुठे मॅडम?
पीके तुमचा नवीन लुक आवडला मात्र मला.
आहेत ना कुठे?
लुक आवडला मला.
गुड.
राजपूत वॉरियर लुक आहे. असा मिशा पिळलेल्या वगैरे.
गल मिशा आहे, गल मिशा.
अभी आपने क्या शेअर केली
म्हणजे पद्मावत वगैरे असं कुठलं तरी एक हे वाटताय तुम्ही.
आज पण थोडा लेट होणार असं दिसतंय.
नाही आता आहे अजून 3 मिनिटं, 5-10 मिनिटं बोलले.
5 मिनिटं. ओके.
पण we intend to start on time. कारण आता ऑलरेडी गुड 94 पार्टिसिपंट्स आहेत, तर इट्स नॉट बॅड.
Hello, Dr. Shailesh. Are you there?
अजून स्नेहा मॅडमच नाही आलेल्या.
प्रशांत.
Yes.
I joined late.
हॅलो डॉक्टर राजेंद्र, तुम्ही म्यूट करा, तुम्हाला अनम्यूट करा. आय मीन
राजेंद्र ऐकू येत नाहीये.
हॅलो 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 मंगला. हॅलो सर.
हॅलो.
काय तू खाली हॉस्पिटलमध्ये केस करून आली दिसतीयस?
मी अजूनही बिझी आहे. मी तुला तेच सांगणार आहे की मी फक्त तुझ्या या टॉक साठी थोडा वेळ थांबू शकते. मला इमर्जन्सी चालूच आहे आणि मी तशीच थांबली आहे. एक तर मी सुरुवात करून तुझं टॉक हे झालं की मग मी निघून जाणार. इमर्जन्सी घ्यावं लागत आहे ऑपरेटिव्ह. ठीक आहे.
जेवण वगैरे झालं का तुझं?
नाही ते मला सवय आहे 6 वाजता जेवायची.
पुढे मॅडम तुम्ही भुयार मॅडमना विचारू शकता केस करून आलात का. कुठे मॅडमना विचारू शकत नाही कारण त्या विचारतील कोर्टातून का हॉस्पिटल मधून.
मी एकटीच आहे की जी फक्त आज सकाळी ऑनलाईन कन्सल्टेशन केले 5. दॅट्स इट.
सुखी आहेस तू.
आमच्याकडे ऑनलाईन कन्सल्टेशन हा कन्सेप्टच नाहीये. वाटलंच तर डॉक्टरांशी 5-5, 10-10 मिनिटं चर्चा करू शकतात, पण कन्सल्टेशन चार्जेबल हा कन्सेप्ट नाहीये.
वाणी मॅडम ऑनलाईन कोणतं केलं? व्हॉट्सअपवर का काही दुसरं आहे ऍप?
आधी नुसतंच ऑडिओ करते आणि जर लागलं मग व्हिडिओ चालू करते. आता
मला वाटलं का दिलीपनी सांगितलं होतं ते ऍप वगैरे असं काही डाउनलोड केलंय का तुम्ही, असं वाटलं मला. नाही का? हा. आता ऑनलाईनला आता करावंच लागेल. आता वर्षभर आहे तर आपल्याला आता ऍडजस्ट करावंच लागेल ते.
आणि ते सगळे क्लिनिक मधून सगळं ते आधी त्यांनी पैसे ट्रान्सफर केल्याशिवाय ते मला कनेक्टच करत नाही, कारण ते नंतर पैसे.
आणि वेळ किती देता तुम्ही त्यांना? 5 मिनिटं 10 मिनिटं सांगितलं असेल ना?
10 मिनिटं साधारण, पण कधी कधी थोडस जास्त, 3-4 मिनिटातही संपतं, डिपेंड्स.
तेवढं कन्सिडर करावं लागतं आपल्याला.
शीला माने मॅडम आल्या होत्या, आहेत का त्या?
नाही, अरुण शिवकडनं सुरू करून आणते, उघडून आणते त्याला म्हणा लॅपटॉप हे घेऊन, नाही तर तसंच घेऊन ये वाटलंस, मला इकडे सुरू करा.
तिला लॉग इन झालेली दिसतेय खरं तर.
हो. मला वाटतं अजून एक 5 मिनिटात स्नेहा आपण चालू करूया.
बिलकुल.
ऑलरेडी 132 पार्टिसिपंट्स आहेत, सो ओके.
हो, बरेच पार्टिसिपंट आले, सगळे फास्ट येत आहेत, आता येतील ते लगेच, त्यामुळे वेळेवर सुरू करूया.
काल 1248 रजिस्ट्रेशन झाले होते.
पण मग लॉग इन का नाही झाले काल? काही चौकशी केली का नाही होऊ शकले?
युट्यूब वरती पण खूप जण गेले नंतर, त्यांना लॉग इनचा प्रॉब्लेम.
मला वाटतं मग लिमिटेड किती परमिशन कितीची होती पार्टिसिपंट?
1000 आहे.
नाही, ऍक्च्युली काल जो प्रॉब्लेम झाला ना, ते खूप सगळे आपलं हे जे शिफ्ट झालं ना ह्याच्यावरनं, मायक्रोसॉफ्ट टीम आणि झूम वर जे शिफ्ट झालं त्याच्यामुळे जवळपास 100 लोकांना तर मीच लिंक फॉरवर्ड केली. आजही 25 जवळपास केले.
Am I audible?
Yes.
Yes, Sheila.
Good afternoon, Sheila ma'am.
Good afternoon.
शीला मॅडम, नमस्कार मॅडम.
नमस्कार.
शीला, अंधारात दिसतेस तू.
हो, नाही करते मी उजेड आता, माझ्यावर उजेड पाडते आता.
उजेड असतो,
दिवे लावा, दिवे.
पराग सगळ्यांना असंच म्हणतो, पराग क्लिअर दिसतो सगळ्यांना, त्यामुळे तो होत असतो.
नाही, मी स्ट्रॅटेजिकली बसतो, म्हणजे जिथे दिवे लावून खूप लावून झाले.
मोबाईल वरती लॉग इन झालाय.
हो. आता शीलाताई आम्हाला चांगल्या दिसत आहेत ना.
Then we do CT test or an X-ray test, even on a patient, where we think that we might have to quickly take her for cesarean section or not. So at least that will give us some clue about, whether this patient, the CT test with healing of abdomen, that gives a clue of some cases lung involvement is there and cautions for. So that is how we are. Thank you, doctor. I think we come on to Dr. Savita now. Dr. Savita, how did you manage that your of the doctor of the paramedic? How do you do that? Duty of
अरे वाणी मॅडम एकटाच कॉफी पितायत, चुकीचं आहे ते. मराठी माणूस फक्त निषेध व्यक्त करू शकतो.
मला आधी मिळालंच नाही प्यायला वेळ, इतकं गडबड, इतकं सॉर्ट आउट करायचं, सॉरी.
बरेच पार्टिसिपंट वाढत आहेत बरं. 165 झालं.
हो, 168. मला वाटतं आता चालू करूया. कुठे गेलं स्नेहा मॅडम?
हो, चालू करा, मी म्यूट करतो आता मला.
आम्ही आलेली आहे. I have come here, but I can't see myself on the panel. Mute. I have.
डॉक्टर मिश्रा सर आलेले आहेत ना?
मंदाकिनी मेघ मॅडम, नमस्कार.
नमस्कार.
Mishra sir, you are ready, no?
Yes, yes.
Yeah, you have checked your presentation and all, no? Yesterday, I think.
Today I haven't, but if you want, I can start sharing.
It's okay now because you have checked yesterday, so you know
Yeah.
how. Yeah.
Good afternoon, Mangala.
Hello,
Good
madam.
Good afternoon, Sneha. Parag.
Good afternoon, ma'am. I was waiting to wish you. Good afternoon.
Thank you. Can you see me? I can't be seen here. तुम्ही मला दिसता? मी दिसते तुम्हाला?
नाही.
ते शफल ते वर जे मार आहे ना व्हिडिओचं ते शफल करा थोडं. हा त्याला जो एरो आहे ना तिकडे शफल करा थोडं.
आणि तुमचा व्हिडिओ ऑन आहे का बघा मॅडम.
आहे सगळं ऑन आहे. व्हिडिओ माईक सगळं ऑन आहे.
नाही बाईक ऑन आहे ऐकायला येतं व्हिडिओ.
So it was wonderful yesterday.
Hello, sir. Hello, sir. Hello, good afternoon.
Good afternoon to all the stalwart present here. Hello.
Manisha.
Yes, madam. Good evening.
Hey, Mangala, PK सरांना अनम्यूट कर थोडं. Sir, good afternoon.
मी मगाशी बोलले ना सर.
हा मग ठीक आहे.
Good afternoon.
हा good afternoon.
Sir, good afternoon, sir. PK sir, good afternoon.
Rajender. Good afternoon.
Good afternoon, sir.
मॅडम कुठे बसलेत? इथे दिसत नाही.
इकडेच आहे.
हा. गुड आफ्टरनून.
दिसत नाहीये जरा.
Good afternoon, sir. Good afternoon. Yeah.
Good afternoon, sir.
Good afternoon, Manisha.
Good afternoon, madam. So nice to see you.
हा. चंद्रपूर अजून खूप तापतंय.
नाही मॅडम थंड झालाय पण कोविड ची एंट्री झालेली चंद्रपुरात. एकाच दिवशी 20 पॉझिटिव्ह आहे.
ओके. ओके.
पाऊस पडला असेल.
पाऊस पडला.
चंद्रपूरला पाऊस भरपूर असतो.
हो सर सगळं काही एक्स्ट्रीम असतं चंद्रपूरला.
ऊन सुद्धा भरपूर असतं आणि पाऊस सुद्धा भरपूर असतो.
इंट्रोड्यूस करायचं का?
मंगला स्टार्ट करते ना.
Hello, good afternoon, everyone. This is
Good
the
afternoon.
second day of our 3 days webinar series on update to breastfeeding. Yesterday was a wonderful day and a lot of discussions, thorough discussions on corona pandemic and breastfeeding. And lot of comments came afterwards, a lot of personal phone calls came to me that it was such a nice session. And people still wanted to ask few questions. So today they are going to ask even on that subject. So this is the second day and today there will be more practical topics that like what happens in the hospital and how we can improve the hospital practices. So again, thank you ICOG-FOGSI Breast Committee FOGSI along with BPNI Maharashtra, IYCF chapter of IAP and Human Milk Association of India, collaboration with Alive and Thrive. So we'll start our second session now, and I invite the chairpersons for the session, Dr. Sheela Mane madam, and Dr. I request Sneha to introduce the chairperson. Sneha is our chairperson for Breast Committee FOGSI, and she has spoken wonderfully the first lecture, the breastfeeding in corona pandemic. And tomorrow she is going to also conduct one panel discussion. Yes, Sneha.
Yeah, thank you, Mangala. It's a good start. I welcome all of you for this afternoon session, second day. And I welcome chairpersons, Dr. Sheela Mane and Dr. Parag Biniwale for this first session of today's. Dr. Sheela Mane, as you all know, she is a very active, a very senior member of FOGSI. And I think we have to mute the rest of the people. He is DNB Professor, KC General Hospital, Bangalore. She was a chairperson of Safe Motherhood Committee. She all of you know, she was a very successful organizing secretary of the recent past AICOG Bengaluru. And we all know her for her postpartum hemorrhage work, PPH. Internationally, we all know her. And she's a grassroots worker, that's what I know. And
Thank you,
very
Sneha.
proud to be associated with her. I welcome you, Sheila ma'am. At the same time, I would also like to introduce Dr. Parag Biniwale, who is alumni of BJ Medical College, Pune, a very close friend of ours. He's the past, at present, he's ICOG secretary, past committee chairperson, Young Talent Promotion Committee. He's the PG guide and unit in charge, Kamala Nehru Hospital, and he's a peer reviewer of many journals. As you know, he's a very dynamic person in FOGSI and ICOG as well. I welcome you, Parag.
Thank you, Sneha.
I welcome both of you and invite to chair this session.
All
Mike
right.
is all yours.
Thank you. Sheila, is it okay if I introduce Mangala?
Yeah, please.
Okay, right. At the outset, I would like to thank Dr. Sneha and the entire team of Study of Female Breast Committee, FOGSI, for having these series of webinar, which are now called FOGSI ICOG Breast Committee Certification Courses. So thank you very much for tagging ICOG along. I bring greetings from ICOG, and it's always a pleasure to introduce somebody who you know very well for so many years. And my pleasure to introduce a very dear friend, Dr. Mangala Vani. She's a senior obstetrician and gynecologist and lactation consultant working in Pune. So for all obstetricians in Pune who face challenges with a patient having any issues with breastfeeding, Mangala is the only savior, and she always helps our patients out. Currently, she is president of BPNI Maharashtra since 2015. She's active executive member of Breast Committee FOGSI. She was clinical secretary of the Pune OBGYN Society, and she is the director of Hirkani Gynecology and Breastfeeding Medicine Clinic in Pune. And she has organized breastfeeding conferences very successfully in Pune for the last 4 years. And she is the first IBCLC in India. This year, she will be conducting the IBCLC course in Pune for the first time. So over to you, Mangala, and we look forward to learning from you in the next 15 minutes.
Can you hear me?
Yes, yes.
Yeah. Actually, Parag, thank you so much. But first lecture was by Dr. Sudhir Mishra. So is it okay if I talk first before Dr. Mishra, sir?
I think that's fine, Mangala.
Fine.
Okay, ma'am. That's okay.
Right. So I'll just share my, just give me a minute. Right. Okay. So can you see the presentation?
Yes.
Okay. So thank you so much, Parag. And thank you again, the ICOG, FOGSI and Breast Committee, FOGSI, giving me this opportunity to coordinate this webinar series, and also, and Meg Madam, and giving me opportunity to talk on this subject. Now, when we talk about the breastfeeding, it starts after birth, the initiation of breastfeeding. So no matter where the newborn takes his first breath, you know, where it is born, whether the baby is born in the posh private hospitals in the cities, or where the baby is born in the forest, you know, the desire to give the baby the best start is universal. And the hours and the days after the birth are one of the riskiest periods in the child's life. And getting an early start to breastfeeding of its powerful line of defense. So first of all, we've been hearing even yesterday that there are 4 recommendations by World Health Organization and UNICEF. So let's see, what is the first recommendation? That help mother to hold the baby in close skin to skin contact immediately after delivery to facilitate the baby to initiate breastfeeding in the first hour of life. So if you see this first recommendation, there are three things. First thing is immediately after the birth, we don't separate the baby and mother. We put that baby on the mother's abdomen. Immediately within few hours after birth. As soon as baby is born and cries, generally once we know the baby is okay, and then skin to skin contact. That means the mother's front is open, the chest and the abdomen. And then the baby is kept. Baby is dried there only on the mother's abdomen. Only we keep the hands little bit wet so that smell of amniotic fluid is still. And then if left undisturbed, this mother and the baby.
You're not able to join?
Infant will latch.
You just send a message on WhatsApp. I will send you a fresh link. Okay.
So these are the three things. So you understand that the baby will self-latch. We don't have to do anything. Only thing is we have to support this mother and the baby. So if you see this newborn, after the birth, it has a highly conserved neuroendocrine behavior. So if you see the baby will cry, then relax. So a lot of activities, and actually the baby can crawl. Means you can see the baby kicking on mother's abdomen. And then it moves forward. He knows where the nipples are, where the breasts are, and the baby can reach up to the breast and start suckling. And that is called a breast crawl. Once the baby finishes the first feed, then baby goes in the longer hours into the sleep, 8-10 hours up to 16-20 hours. And then baby may not take the feed after that. So that is why the initial period is very, very important. Now, when we see this, it is so simple. We just put the baby to the mother's abdomen. But if you see the figures in India, what is happening? The initiation happens within 1 hour is only 41.8%. That these are the NFHS 4 survey. And exclusive breastfeeding up to 6 months is only 54.9%. So this was the very position paper in the pediatric journal, that if there is a separation between mother and baby, what happens? There is a toxic stress in the baby. So we'll see. Also, if you see the mother's chest, the lactating breast and the chest, the temperature is higher, about 4 degrees higher compared to non-lactating breast. So that is to keep the baby warm, to prevent the hypothermia. You also see when the baby and mother skin to skin contact, the transition score is smooth, the heart rate, the breathing score, everything is smooth. The baby is very stable. And there is a bond between the mother and the baby. Mr. Bowlby has done a lot of work on this mother and the baby bonding. So through hidden maternal regulators, the mother precisely controls every element of her infant's physiology, from its heart rate to release of hormones and its appetite to intensity of the activity. So mainly the warming, feeding, protection behaviors, they are intricately, inseparably linked to the right place. And now the skin to skin contact, it also causes breastfeeding. Cochrane database proves that in 1916, that paper is released, 2016, I mean. And what happens with the skin to skin contact after birth? Even it is 8 times more likely to breastfeed the baby. And there is a clear dose response relationship between skin to skin contact in the first 3 hours post birth and exclusive breastfeeding at discharge 3 and 6 months. The engorgement is also less, and it is very cost effective program for mother and child. So a lot of benefits from this skin to skin contact. We spoke earlier, there is a physiological stability. Blood glucose levels are in fact higher. There is a thermoregulation, reduced NICU admission, and baby is calm. Baby cries less. Baby sleeps better. And there is a colonization of the newborn to maternal flora to protect infections, against infections, and particularly from necrotizing colitis in the preterm babies. There's a bonding and there's an increased success of the breastfeeding. So it eases actually the infant's transition to extrauterine life. And this benefit persists years later, I would say throughout the baby's life. There are a lot of maternal effects as well that increases the maternal oxytocin level. And oxytocin level, we call it as a love hormone, which antagonizes the flight fight effect. It reduces the maternal anxiety, maternal stress. Mother is also calm, and it increases the parenting behavior in the mother. It improves the bonding, expulsion of the placenta quicker, reducing the postpartum hemorrhage, and increasing the breastfeeding success. So when mother and the baby separated, that leads to toxic stress in the baby. There is increased cortisol levels in the baby, and it in fact disrupts the brain architecture and leads to stress management system that responds at relatively lower threshold. So this resilience is lower in these babies and increasing the risk of stress-related physical and mental illnesses. So you can see on the left side with the skin-to-skin contact, more oxytocin. On the left side with the separation, there is a more cortisol. So a lot of animal studies being done. So on the left side, you can see nice those babies and moms together, high leaking, grooming. There are low cortisol levels, low anxiety. And on the right side, how the babies are separated, like our babies are in the cradle or somewhere, you know, and the mother is somewhere, she's sedated. So these babies has a high cortisol levels, high anxiety, and they actually develop into unhealthy adults. You know, they come across, they have a lot of illnesses when they go into adulthood. So early stress alters gene expression with health impact across lifespan. And of course, delayed skin to skin and initiation may suppress newborns' innate protective behaviors. So breastfeeding could be a problem, bonding could be a problem, and negative effect on even maternal behavior that she may not handle the baby properly. And there may not be immediate the response when the baby is crying. So the lot of research, it says the longer the interval between the birth and the first feed, greater the risk of dysfunctional attachment. And the first hour breastfeeding in the practice most predictive of exclusive breastfeeding in the hospital after vaginal or C-section deliveries. So friends, what we do or we do not do in the first 3 days, especially in the first 1 hour, influences the duration and exclusivity of the breastfeeding. And it is a very critical ingredient in the long-term breastfeeding is adequate milk supply. So earlier the milk starts coming out of the breast and there's a stimulation of the breast, there is a more milk is produced and longer term the milk is produced. And particularly first hour, suppose the mother and the baby is separated, then we should remove that colostrum and we should give that to the baby. So you can see there's a separation. So we remove the colostrum. Now colostrum is a very small amount. So instead of taking a little katori, what we do, we just collect it in the syringe. Because otherwise katori, it will be stained to the wall only and it will be wasted. So with the syringe, even the few drops, the baby will get it. But this process should start immediately after birth. The colostrum is rich in antibodies, you know, particularly IgG antibodies. Also, it causes peristalsis and encourages early passing of this bilirubin-laden meconium and reducing the chances of baby getting this neonatal jaundice. It also helps to complete the maturation of the intestines and it is rich into vitamin A and K vitamins. So colostrum is small in amount, but it is enough for baby and very, very important. So no prelacteal feeds to be given. What is prelacteal feeds? That means anything which we give before the first feed. So if we give something else to baby, baby's stomach is going to be full and then the baby will not desire for breastfeeding. Again, baby thinks this is the way I get the food and baby may have a difficulty latching at the breast. Baby may chances of infection, even risk of allergy because it is a foreign protein. So what are the barriers? Why it is not happening? So there are lots of myths and misconception in the society. You know, the myths means in many families or many societies, they discard the colostrum. They think it is not good because it is collected in the breast so many months, it is not good. In some places, the priest has to come and then chant some mantras. Then only they give the baby the first feed. Now, suppose the baby is born late after 9 or 10 o'clock in the night. So the priest is not going to come in the middle of the night like the obstetricians, they come. And then they have to wait till morning, till the priest comes. So that means that initial golden hour is gone. The family support. Now, who is the main decision maker in the family? The mother-in-law. I know all mother-in-laws are not bad. Some of you are mother-in-laws. Myself, I am a mother-in-law. But, you know, sometimes they are so dominant and they make the decisions and it is very difficult. So that is where the importance of antenatal classes and educate them. I just give you one example or rather story. We go in the rural areas and, you know, do for training in Anganwadis and all. Once we were doing one training and I was called because they knew I'm a gynecologist as well, because there is some deliver happened nearby and that lady had little more bleeding. So I went. So by that time that PhD sister also came. So we did all preliminary things and it was not bad. It was okay, she settled down. So when I came out, I saw the mother-in-law holding the baby. And already she had this milk, cow's milk in the katori. She was sitting on that little bed, you know, baths we call. And there was a mattress which was even torn here and there and dirty cotton was peeping out. So what she did, she pulled the piece of cotton from that mattress. She soaked that in the milk and then she squeezed that milk into the baby's mouth. So you can imagine, you know, already baby has no colostrum, no immunity, and plus how much infection. So I felt so helpless. And I thought I was better off rather than like IVF consultant. It is so easy. They are so inspired and promoted. They want to have a baby and they do everything. Here breastfeeding, there are so many obstacles. Very difficult, you know, to counsel the patient and the family. Routine formula supplementation happens in most of the hospitals and of course the hospital practices. So what happens, giving formula in the hospital doubles the risk of discontinuing the breastfeeding. Now if you see the picture on the left hand side down, there is this formula and then there is a nipple shield, the long nipple shield, the old type, which we don't use this type of nipple shields anymore. Dipti will cover that later on. And the syringe. So what they do in the hospital, they put the nipple shield in the baby's mouth and then they put the milk by syringe. So you can see the artificial nipple has gone into baby's mouth. The milk ready-made has gone into baby's mouth. So this baby will have a difficulty latching at the breast. And plus the breastfeeding is not going to be successful. There is no initial stimulation of the breast. So she will have a problem getting the milk in. Now there was a survey done on the Facebook. How many mothers ever saw a baby being breastfed? So 50% saw a never baby being breastfed. You see in the media many times the baby fed by the bottle. And we are seeing that as a norm. And many has not seen even as a kid, not in normal day life, not on the TV show or movie. Everywhere there is a bottle. So those mothers, they find difficulty because they haven't seen. Now, if you see right hand side, there's a picture of the gorilla and the baby. Why I have put recently, I have seen that in US, in some museum, the gorillas, they started refusing the breastfeeding. Apparently because the caretakers were giving the baby the other milk and they are forgetting the art. So it was a big issue. Ultimately, the local breastfeeding ladies, they volunteered. They came in the zoo. They sat in front of these gorillas and they started breastfeeding their own babies. And seeing that, these gorillas restarted breastfeeding their babies. So see this power of you see something and then you do the same thing. So we have to change the whole scenario. the mothers should breastfeed in the public places even, so that the first time mothers, they learn from this. The hospital practices, what we do as soon as the baby is born, we keep the baby in the warmer, and then the pediatrician comes, examines the baby, we do the suctioning. What happens, like we go to the dentist, we don't like even that suctioning, the noise. And that baby just born and there is so much trauma, suddenly going something in the mouth. And that baby sometimes mentally so much traumatized, it doesn't open the mouth for days and refuses even the breastfeeding. So normal, healthy term baby, it doesn't need a suctioning. Only few cases, for example, meconium or something like that, they need suctioning. Vitamin K injection, the swaddling that you see in the picture. Sometimes I have seen in the hospitals, the bath is given immediately. First 24 hours, no need. Actually, many now hospitals are changing the policies. So 2-3 days they don't give bath. That is good thing. Weighing the baby, putting the clothes, and then the baby is given to the relatives. So we have to change all these practices, and just baby putting on the mother's abdomen, skin to skin, and breastfeeding. Now, next is the main dilemma is after cesarean section. How it is going to happen? This is in one of the hospital. And what happens, you see this picture, this is a cesarean section lady. Just lying down, she's been sedated, and the baby is probably transferred to her room. And look at her dress, even it is not front open, close, open dress. So there is no question of even skin to skin contact or breastfeeding. So it is delayed then breastfeeding. So we have to change this scenario. So in the operation theater only, we should start the breastfeeding. I'm sure we get the husbands also in the operation theater, and it is a family business. The skin to skin, the other side, still the section is going, the stitches is going on, but there can happen. And see, we can hold the baby. This is my baby. Say hello. So when the mother is lying down, the anesthetist needs to be, of course, cooperative, and over the shoulders, the staff can hold and baby can be breastfed nicely. So there is no problem whatsoever. Even after cesarean is over, we can give. Only thing is the staff needs to be trained. The routine has to be changed. And look at, see how mother is happy. She doesn't need any sedation. My section ladies, they don't get any sedation, because if they're sedated, they won't be responsive, during the breastfeeding. So, and even they need a less analgesia then. So after cesarean section also, the initiation is possible. After going to recovery also, the staff again call the relatives and they just tell them how the baby is to be held. After a few hours, mother can turn on one side, this side, and lying down position also she can breastfeed. Now, this was a very important research done in Ghana, published in 2006. So, first hour initiation cuts 22% of all the neonatal deaths. So, from 11 lakhs neonatal deaths, 2.5 lakhs neonatal deaths can be prevented just by 1 hour initiation. This is very important meta-analysis published in 2017, and more than 1.3 lakhs of the infants. So you can see the around 24 hours, the first 1 hour is very, very optimal. And if there is a delay between 2 hours to 23 hours, the increases the risk of the neonatal death by 1.3 times. And if the initiation happens more than after 24 hours, then the risk of neonatal mortality is double, more than 2 times. So initiation within 1 hour is so powerful, reducing the infant mortality. Now, countries meeting minimal support for breastfeeding, so far none. We can do better, yes, we can. The breastfeeding is one of the smartest investment in a country. And breastfeeding is one of the best investment in global scenario. Every £1 invested in breastfeeding generates 35 pounds in economic returns. You are not going to get any returns like in any investments anywhere. So to improve the practices, there is something called baby friendly designation, which session we will have later on. So we can see as soon as the BFHI practices, the breastfeeding initiation and breastfeeding rate increases. So this baby is asking to all of us, why such breastfeeding rates are so low, and what you are going to do to help me to lead the healthier life. I'm more stressful, my mortality is more, my morbidity is more, I get more infections. So obstetrician's role in promoting and supporting breastfeeding is very important, because we are seeing the patient for 9 months. We can do the anticipatory guidance, and we can conduct the antenatal classes. And antenatal classes is again another powerful tool. They get motivated, inspired. Multiple studies provide evidence that formula feeding is associated with increased risk of infants and mothers compared with breastfeeding. So by supporting breastfeeding as the normative way to feed an infant, the obstetrician gynecologist can play a powerful role in improving the health outcomes across 2 generations. We have to improve the hospital practices and breastfeeding success. The patient perception of clinician opinion is directly associated with breastfeeding duration. So whenever she comes to visit us during pregnancy, we can just talk 2 minutes about breastfeeding. Just tell her about some benefit, tell her what can happen, what difficulties she can come across. So she is aware, she understands. So the world is not dangerous because of those who do harm, but because of those who look at it without doing anything. So much formula is been given, so we have to stop that. So thank you so much.
Thank you. Thank you, Dr. Mangala. I think it was a real learning even from many of us, and I can see from the chat also that many people are happy to hear, and the message is really been given to them. So thank you very much, and I would like to know whether we are going to take question and answers now or later.
No, at the end we'll take.
Yeah, thank you very much.
Thank you.
Now I think we will invite Dr. Sudhir, the next speaker.
Yes, please.
Yeah, okay, fine. We'd like to invite now Dr. Sudhir to deliver his talk, and thank you for the adjustment when Mangala had to give a talk before you. Nice gesture from your side. Just a minute. Dr. Sudhir Mishra, he is the head of the Department of Pediatrics at Tata Main Hospital, Jamshedpur. And he is also a member of CIAP, life member of IYCF chapter of IAP. I think I would like to know from him what is IYCF. And I think we are here to learn many things from you, and you can share your experiences. Welcome you, Dr. Sudhir Mishra, for your today's talk on risks of non-breastfeeding. I think it's very important, as just now we saw in even Mangala's statistics, what she gave, that only 41% of the mothers, they feed the baby as soon as the baby is born. So I think it's very important to know the risk of not breastfeeding. And I think many mothers face this problem nowadays. In my practice, what I find, I don't know, which never is to happen 10 years before, but the mothers nowadays, they have so much of difficulty in feeding their baby that we have we have to call lactation specialists. Our nurses are trained, but why was not happening 10 years before and why it's happening today? That's a real mystery. Anyway, over to you, Dr. Sudhir Mishra.
Thank you, Dr. Sheila Mane. I would like to thank the FOGSI, the IYCF chapter, of course, of which I am a part. And also the Alive and Thrive and the VPNI and all other agencies that have come together to really make it possible. IYCF is infant and young child feeding. That is, ma'am, to answer your question on what IYCF is. So this chapter of Indian Academy of Pediatrics basically deals with the feeding issues of the newborns as well as the older children. And also, I think 30 over
Some problem with audio.
I dedicate this talk to these wonderful working women. Two of them.
Hello, Mr. Vishal. I think there's some problem with the voice. Yes.
Dr. Mishra, sir, is there one more instrument on near you? Hello?
Hello?
Is there one more instrument on near you, another mobile or something?
Near me?
Yeah?
No, ma'am. No.
No. Okay. Okay, you can start.
It's mute for him. He has to unmute first.
Vishal?
Yeah. Yeah, ma'am.
Yeah, please unmute Dr. Mishra. He's still mute.
So, Dr. Mishra, he was speaking just now. 1 second.
I think Vishal can do that.
No, he'll have to do it himself actually.
Yeah.
There now.
I don't know how was it unmuted automatically. Can you see my screen? Can everybody see my screen?
No.
You have to share again.
You have to share first.
Share the screen.
It was already shared.
Yeah, it's on now.
Now it's okay.
Can you see it now?
Yes, perfect.
Okay, I think probably something got missed in between. Am I audible?
Yes.
Okay, so I would start again by thanking the FOGSI, the VPNI, the Alive and Thrive, and of course the IYCF chapter for giving me this opportunity, and Dr. Mangalavani personally for speaking to me and inviting me to this forum. It's a wonderful opportunity. Also, her starting this topic on advantages of breastfeeding was, I think, natural, and it was a wonderful talk. Thank you, ma'am, for enlightening us. That makes my life or my job easier. I dedicate this talk to these working women. Two of them.
Sir, your voice is breaking.
Dr. Mishra, I think there's a problem with the voice.
I think internet is unstable there. Internet is unstable.
Of course, the third Indian lady, and we see many such ladies. It's raining. You will have to bear with it. Am I audible?
Sir, now you are audible. I mean, in between there.
Now I'm audible?
Yes.
Okay. Okay. So I go to the next thing. So what is the advantages of breast milk in terms of contents, what it takes? So all the milks will provide these basic things, the water, protein, carbohydrate, minerals, etc. But what is lacking is these antibodies, hormones, antivirus agents and all, and I'll go into little greater details. One important thing that is growth factor that is not there in any top milk or any animal milk for the human being. So this talk will be in terms of the advantages for the newborn baby and for
Internet unstable actually at his end.
Of not breastfeeding. Now, you know, I had a 5-layer security, but the breast, hello, probably because of the thunderstorm and rains that is there, I can't help
Yes,
that.
I think so.
Hello, shall I continue? Or shall I, or alternatively, somebody else can speak and wait for this thunderstorm to go, then I can take.
Now I think we can hear you.
You can hear?
Yeah.
Okay.
Yes.
So this breast milk provides a 7-layer security to the baby, and because it is sterile, most hygienic, there are glycans in it which inhibit pathogens. There are oligosaccharides that retard the growth of pathogen and cause cell lysis as well. And there are can't hear? Hello.
So you're audible.
Yeah, we can hear you very well. No problem.
Thank you, ma'am. Thank you. Secretory immunoglobulins are there. Then there is lactoferrin and growth factors that promote epithelial growth and repair the damage fast. And there are lactobacilli and bifidobacterium that create hostile environment for pathogenic bacteria and thereby preventing the infections. Now, the short-term risks for the infants, especially the newborns, are that it lowers the sepsis. How much? By a factor of 0.27, that is about 27%. And some studies, they go as high as 0.95%. It lowers the risk of urinary tract infection. And Madam has already told about the NEC. If you look at where the low amount of human milk was provided, the incidence of NIC was 10.6%, and where the baby was fully breastfed, the incidence is only 3.2%. So it's 1/3. It reduces the risk of NEC by 1/3, and that's a great advantage. If the gestational age is factored, you will see the odds ratio is 0.17, which means of all the babies, if they are breastfed, they have 17% chances. So different studies have the figures varying a little bit, but then that is the situation. Now, even the partially breastfed babies do prevent infections, and Madam has already highlighted all these, the immune cells, the immunoglobulins, the cytokines, the nucleotides, etc., that help in reducing the infection. But what is important is that babies fed on human milk, they have less chances of apnea and desaturation. Now, this study, what they did was they tried breastfeeding and bottle feeding with the same babies at different times. And then they saw that the temperature and the oxygenation both were higher in breastfed preterm babies. So this helps in, proves that it helps in reducing the oxygenation and the apnea in the preterm baby, and thereby helping with the survival of babies. The chances of SIDS are less. SIDS is sudden infant death syndrome. Sometimes we find that absolutely normal baby, we reach in the morning and find the baby dead. So that sudden infant death, if you look at the HRS hazard ratio, for non-breastfed baby, the hazard ratio is 10.5 compared to partially breastfed, that is 2.46, if we take hazard ratio of 1 for the exclusively breastfed babies. So 10.5 times higher chances of SIDS compared to exclusive breastfeeding. And even if it is continued for only 1 month, it reduced the risk by half. And if, of course, for 6 months, it is 10 times reduction in the risk of SIDS. Now, this is a very important slide. If you look at the top-fed versus the breastfed baby in terms of neonatal mortality, and because these studies are, many of these studies are conducted as top-fed as the standard and breastfed as the interventions, therefore this forest diagram might appear reverse. But if you look at comparison between predominantly and exclusively breastfed baby, you will find some advantage. But if you look at partial versus exclusive breastfeed, this advantage is great. And if you look at no breastfeeding versus exclusive breastfeeding, there is huge advantage of mortality, which ranges as high as 21.56. Madam has quoted some study where 27% was there. So you can say roughly mortality by virtue of breastfeeding. And what is important is that even that also helps. So it should never be that you don't breastfeed at all. You continue to breastfeed with whatever amount you can give if exclusive breastfeeding for some reasons is not possible. For the infants, of course, older children, we all know it reduces diarrhea, but what is more important is that it reduces the lower respiratory infections, that is pneumonia, by about 27%. And in another study, it found 72% reduction in lower respiratory infections because of exclusive breastfeeding. Similarly, every month of partial breastfeeding in one study showed a 31% reduction in diarrhea and 27% reduction in lower respiratory infections. Bottle feeding predisposes to otitis media, and compared to a bottle-fed baby, an exclusively breastfed baby will have a 50% reduction in exclusive breastfeeding. If you look at post-neonatal deaths, that is deaths after 30 days, overall 16% of neonatal deaths could have been averted by the breastfeeding, but not in developing countries or underdeveloped countries. Even in, because India is like, it is developed country for some, it is underdeveloped, and it is developing for some. So even if you look at the developed countries, because people from higher strata often argue that we will maintain full hygiene, we'll maintain everything, we'll have 20 bottles, we'll sterilize them well. So for them, this is very important to see that odds ratio of death because of the exclusive breastfeeding, they were reduced by 0.59%. That is, if the baby had a chance of death, it was reduced by 0.59, 0.59, that is the odds ratio, that is 0.59 out of 1, so 59%. And for sudden infant death, it was 0.84. So again, the same issue, that it reduces the mortality considerably in neonatal as well as post-neonatal period, not only in underdeveloped and developing countries, but also in developed countries, that is the highest socio-economic strata of our population, if we want to say that. With all-cause mortality, the predominantly breastfed babies, they had the risk compared to breastfed 5 times. Partially breastfed had 4.8 times compared to exclusive breastfed. Non-breastfed had 14.4 times higher mortality. And even in the times beyond 6 months of age and up to 23 months, the mortality was 1.8 and 2 times higher if you have given exclusive breastfeeding in the first 6 months. So the impact of exclusive breastfeeding remains at least till 2 years, and many believe till 5 years. Now, this is again, if you look at the median of 1 and top fed versus breastfed, all studies except this one small study are showing an advantage of exclusive breastfeeding, and the range is, as great as 22% or so if you have exclusively breastfed. So it's not, this is a meta-analysis data from a study that included about 23 studies on the subject. Now, if we look at the long-term outcomes, obesity in children, and this is a spatial diagram where 0% to 22, these are about 27 countries in which this was created. If you look at this kind of light gray diamond, this is for exclusive breastfed, this is for partial breastfeeding less than 6 months, and the circle is for non-breastfeeding at all. And you see across the country, almost all countries, you will find that the percentage is higher when the baby is not breastfed for obesity. And we all know what all problems obesity brings to the children and the family. If you look at the childhood cancers, again, if you look at this, the acute lymphoblastic leukemia is certainly one leukemia or one cancer that is prevented by breastfeeding, and the odds ratio is 0.81. That means it has almost 19% reduction in leukemia if you have exclusively breastfed your baby for 13 months. for almost first 6 months, definitely. It is much less for the AML, and there is no association for solid tumors. So I'm not saying it prevents all types of cancers, but it definitely prevents acute lymphoblastic leukemia. In terms of the allergic disorders, there are two important things. The relationship is much less clear for the atopic dermatitis, but there is consistent relationship in reduction of asthma if the baby are breastfed. Now, there is 27% reduction when there was no family history of asthma. But if you look at where there is family history of asthma, it becomes far more important. The reduction is to half the chances of asthma if you have family history of asthma by simply breastfeeding the baby for 6 months and continued till 1 year. If you look at cognitive and mental development, these three diagrams, what they show is, this is for first year, this is for second year, and this is for third year. So 3-year study, and you will see that longer the breastfeeding, greater is the advantage in terms of intelligence or mental development index. So it is here compared to formula only, that is 97, so about 8 points advantage. Here again about 6 points advantage, and here again about 6 points advantage. So 6 to 8 point advantage in terms of mental development index or in, IQ is there with the exclusive breastfeeding for 6 to 12 months. I mean, for 6 months exclusive and then continued breastfeeding for 12 months. If we look at type 1 diabetes, and these are 43 studies pooled, and you will see that this is a typical forest diagram wherein the data going on the left side is an advantage, data going on the right side is not an advantage. And you see most studies have found an advantage, and there is about 19 to 27% reduction in type 1 diabetes in children if the baby is breastfed only for 3 months, and about 39% reduction. And we are seeing increasing incidence of type 1 diabetes in our society now. So breastfeeding will go a long way in controlling it. Now, there are some maternal risks which may not be as clearly laid out or known. So that is very important to know. First is the sleep, because most people give this argument that we feed the baby with top feed in the night so that mother can get some rest. But in this study, if you look at, the breastfed mother actually got 45 to 60 minutes of extra feed compared to a type-fed mother. And this was even when the father took the responsibility of top feed. So that is because once the baby cries, mother does wake up and goes back to sleep very fast if the baby is given breastfeed. But if you have to get up, prepare the formula and all, the sleep disturbance continues. So this is a myth that needs to be broken. Maternal weight loss, the last word is not yet out, but there are major studies that show that mothers lose weight faster if they exclusively breastfeed for first 6 months. The relationship is not so great beyond first 6 months. However, there are contrasting results from some study, and therefore I say the final word is not yet out. And this is probably because there is multiple compounding variables, the diet of the mother, exercise, smoking habits, etc. They come into play, and therefore the weight loss is not that consistent. But what is most consistent is postpartum depression, and there is 6 to 18% reduction in different studies of the postpartum depression. There are studies that have found that increased the incidence of breastfeeding was found if the baby was not breastfed, and the depressed mothers are more likely to stop breastfeeding. So perinatal depression or postpartum depression is a very, very important thing that can be prevented to some extent with the breastfeeding. These findings are very, very consistent across multiple studies. There is no confusion about that, no doubt about that. Now, if you look at mother's blood pressure, so somebody studies these mothers with PIH, they were there, and you will find that with the exclusive breastfeeding, the blood pressure were about 10 millimeter, 8 to 10 millimeter lower systolic, but there was not much difference, only of about 2 to 3 millimeter in the diastolic blood pressure. So the mothers with PIH especially will benefit but all mothers will have this lower blood pressure. And lower blood pressure means that their chances of developing hypertension later in pregnancy also reduces. It's again a similar study showing the same thing. All these 6 studies that were used in the meta-analysis showed some advantage. A lot of studies, they show large advantage. These 2, of course, showed mild advantage. Doesn't matter, but there is definite reduction in mother's blood pressure according to this. Then there is metabolic syndrome, which essentially consists of obesity, insulin-resistant diabetes, hyperlipidemia, and hypertension. And there is a risk ratio of 0.77 if you have exclusively breastfed. So if you have not breastfed, if the risk is 1, if you have breastfed, chances of developing metabolic syndrome, which is later on leads to a lot of complications like cardiac stroke, the brain stroke, or the CNS problems, inability to walk, osteoarthritis, and whatnot. So this can definitely be reduced with the exclusive breastfeeding. There is great reduction in rheumatoid arthritis incidences, and this is probably because of the higher level of female hormones, the progesterone and the prolactin that are secreted in the while the mother is breastfeeding. If you have breastfed for more than 12 months, the odds ratio is developing rheumatoid arthritis 0.46. That means there is 54% reduction in the incidence of rheumatoid arthritis. And if you have breastfed from 1 to 12 months, there was still a reduction of about 26% in the incidence of osteoarthritis. So even the rheumatoid arthritis incidence is less for mother. There is reduction in type 2 diabetes mellitus, but this reduction in type 2 mellitus was far greater for the mothers who did not have gestational diabetes. Reduction was only 4% where the mother had gestational diabetes. Clearly, the mothers who are predisposed to diabetes genetically and have the gestational diabetes have less chances of saving themselves through breastfeeding. But the mothers who do not have gestational diabetes are at a great advantage, about 37% reduction in the gestation, in the diabetes. Now, many people are worried about the fact that breastfeeding leads to osteoporosis. No, breastfeeding does not lead to osteoporosis. Multiple studies, all of them have found that there is no difference in the incidence of fractures or the bone mineral density carried out, except one study which showed a reduction in bone mineral density in the forearm bones, not in the pelvis bones and other bones. So similarly for fracture, there is no multiple studies. All have seen no difference in the incidence of fractures after the breastfeeding or in the bone mineral density at all. So just to summarize all these factors for the baby and mother, they are, I think, what Dr. Mangalavani showed us, the investment of $1 returning $35. All these factors, they actually lead to this gain breastfeeding. I'll not read out each one of them. You have already heard that. Thank you very much. Now, breastfeeding goes across borders. We might keep fighting on the borders, one country with the other. Nowadays, it is China versus India. But the advantages of breastfeeding, they do transcend all the borders. Thank you for your patient listening. I'm sorry for the rains and thunderstorms causing intermittent disturbance. Thank you very much.
Thank you. Thank you. Thank you, Dr. Sudhir Mishra. Parag, would you like to? I think very you elaborated about all the benefits. I think it is so important. I think to have a healthy population tomorrow, I think we have to really stick to this. Parag, your comments?
Yeah.
Parag?
Yes. Can you hear
Parag,
me?
your comments? Yeah.
Sir, it was a very, very informative lecture. We as obstetricians are always concerned about the mother's health, and you've given us some tips as to how to counsel women as to what are the benefits of breastfeeding and what all problems we can prevent in the future. So thank you very much for joining us and enlightening us.
Thank you for that.
Yeah. Yeah. Shall we invite the third speaker?
Yeah, please go ahead.
I think Sheila madam, you have the biodata.
Okay, fine. I'll do that.
त्याला बोलून घेता का दिनेशला समजा वाटलं तर काही.
It is
yeah. Hello.
Dr. Alka Kuthe.
Yeah, hello, Dr. Alka Kuthe.
Hi.
Hi. So, Dr. Alka Kuthe, she's a consultant obstetrician and gynecologist, and she has also done her LLM as well as PG diploma in human rights education, and she is the ex-president of BPNI Maharashtra State, founder member of Human Milk Bank Association of India, and she's a member of FOGSI Breast Committee and a past chairperson of ICOG-FOGSI Medical Legal Committee. She's a receiver of Dr. N.B. Kumta Award for dedicated and outstanding work in breastfeeding and IYCN. I know her passion for this subject. I think we participated in a debate in Indore, and that time I knew that Alka is thorough in this topic too. Over to you, Dr. Alka.
Hi. Are the slides visible?
Not yet.
Okay,
You have to share the screen.
Yeah. Wait, I'm.
Yes, it has started, ma'am.
Now, can you see?
Yeah, you have to make it in presentation mode. It started.
Okay.
Yes.
Yeah. So, namaskar, Saganna. Good afternoon. At the outset, let me thank Dr. Mandakini Meg madam, our own madam from Amravati, Dr. Sheila Mane madam, and of course, my Dr. Mangala Vani madam, President BPNI Maharashtra, and the whole team of Alliance 5 who have made this ceremony successful, this CAB successful. And actually, the opening batsman was Dr. Mangala Vani madam, and she has given a lecture on initiation of breastfeeding. And actually, you know, when it is well begun, it is half done. So Sachin Tendulkar was there, and she has played a nice inning. Now I had to play the remaining part. Aristotle has very rightly said, there is reason behind everything in nature. So whatever we get from the nature, there's some purpose behind that. And a pair of mammary glands given to the human being, given to the mammals, does the extraordinary function of breastfeeding. Breastfeeding is natural, instinctive, and physiological. You know all these things. This is our culture, actually Indian culture. But what happened? We forgot our own culture. We followed the Western style just blindly. And that's the reason why Alliance has organized this seminar. Breastfeeding is breastfeeding. Keith Hansen, World Bank official, has rightly said, if breastfeeding did not already exist, someone who invented it today would deserve a dual Nobel Prize in medicine and economics. That shows the importance of breast milk from medicinal point of view and from economical point of view. Benefits of breastfeeding for the infant. I did not go into details. All nutrients in proper proportion for healthy growth and optimum development of the fetus, of the infant. Less illnesses, no disease or less diseases and disorders. Antibodies in breast milk protect the baby. Always it is available at the right temperature, easy to digest. There are many nurturing benefits from skin to skin contact. Breast milk aids in development of the baby's brain and nervous system. This is very important in today's era. By 1 mark, our admissions in medical colleges, they have to get deprived just by 1 mark. So in this era of competition, brain development is very important. Again, many advantages to mother. Decrease postpartum bleeding, earlier return to pre-pregnancy weight. This is also very important because they want to maintain themselves. So the modern mother wants to maintain herself. So earlier return to pre-pregnancy weight rather. Delayed resumption of ovulation. This is fantastic advantage as far as contraception is concerned. Indian population is concerned. There are always reduced risk of ovarian cancer, less chances of osteoporosis, reduced premenopausal breast cancer. This in nutshell about the advantages to the mother and to the baby. These are the three major killers in India. When we go to the statistics, under 5 childhood deaths, we find that neonatal sepsis, diarrhea, pneumonia, these are the three major killers. And if exclusive initiation of breastfeeding, exclusive breastfeeding, 2 years and minimum 2 years of breastfeeding with 6 months homemade complementary feeding, the standard optimal IVC practices are adopted, these rates can be reduced significantly. These are the 10 steps to successful breastfeeding. That is BFHI, that was revised in 2018. These are regarding key clinical practices. Step number 4, 5, 6, 7, 8. All these give importance to the uninterrupted skin-to-skin contact with support to mothers to initiate breastfeeding as early as possible within 1 hour. For that, give uninterrupted skin-to-skin touch to mother, to baby, to mother. Support mothers to initiate and maintain breastfeeding and look at the difficulties she faces. Do not provide breastfed newborns any food or fluids other than breast milk unless medically indicated. Enable mothers and their infants to remain together and to practice rooming in, not only rooming in, bedding in, that also kangaroo mother care, skin-to-skin contact. Support mothers to recognize and respond to their infant's cues for feeding. We will be discussing this issue later on. What are the, who need breastfeeding advice? In the postpartum period, primary para, mother of twins, mother who has undergone cesarean section. These are very important. Sick mother, mother whose baby is admitted in NICU, baby who is having congenital oral cavity anomaly. They need breastfeeding advice. And we as a healthcare provider should be there always to help these mothers. What are the common problems they face? Whenever I take postpartum round, most common complaint is, Madam, doodh hi nahi aata, no milk, less milk. How many times I should breastfeed the baby? Latch-on difficulties. How to position and hold the baby while breastfeeding? We can see the cases of cracked nipple, retracted nipple. The mother feels her milk is not adequate for the baby, so she should give something, top milk or some infant formula or infant milk substitute. So promoting and protecting breastfeeding in 48 hours, first 48 hours, very crucial. It is said that first hour, first day, first week, first year, they are very crucial as far as breastfeeding journey is concerned. Always give a calm environment to the breastfeeding mother. As hold the baby's skin to skin. She should hold the baby's skin to skin contact. They should be proper latch on. Breastfeeding positions we should observe. The mother should be taught to keep the baby awake while breastfeeding, and she should have knowledge how to recognize that baby is hungry, how to identify the early feeding cues. These are the things for which they require our advice. It is not that each and every mother we should look for, there is cracked nipple, there is a retracted nipple. It's not necessary. The mother complains to us, we must go for that, how she is breastfeeding. Skin to skin contact, again, I need not go into this slide because Madhana very nicely elaborated on this point. It's a natural behavior for most babies to slowly crawl towards the breast. This we call as breast crawl. This is because of uninterrupted skin to skin contact. Mother should be supported to help baby to the breastfeed if desired. If require support, we can give the support. It triggers the production of breast milk and accelerate lactogenesis. There are 3 types of lactogenesis: lactogenesis 1, lactogenesis 2, and lactogenesis 3. This discussion, we'll discuss this later on. So what are the correct breastfeeding techniques? There are 12 points. First 4 points under attachment. Maximum possible area of the baby's, of the mother's areola should be inside the baby's mouth. Lower part more, upper part of the areola can be visible. Baby's mouth should be wide open. Her lower lip should be turned outward and chin should touch the breast. These are the 4 things that come under attachment, rather latch on. That is very important. So you can see the picture or figure how well the baby is attached or latched on the mother's breast. So these are the, again, 2 pictures. The first picture showing baby is taking baby is having proper latch on, and so the baby is getting enough milk, adequate milk. While in picture 2, we just see the nipple suckling. The latch on is not at all proper. So baby will remain hungry because the baby will not receive any milk from the mother. So first picture is correct latch on, second picture is wrong latch on. Again, this is correct latch on. You can see the position of the lips, the cheeks, and how is the nose kept, where is the mentum on the resting on the mother's breast. So what are the indicators of effective latch? The upper and lower lips are flanked outward. The tongue is cupped under the breast and it is visible above the lower gum ridge of the baby's mouth. The infant is using wide gliding jaw movements. There is no pain or trauma after feeding. Mother tells that it is painless, no trauma to the nipple, and she doesn't pursue any pain. What are the signs of an ineffective latch? The lips will be tight, pursed lips, lower lip will be pulled in. There we can see dimpling of the cheeks of the baby, and the mother will report there is pain while breastfeeding. The nipples will be flattened or misshaped following feeding. So these are the signs by which we can come to know that it was an ineffective latch. Clicking or smacking sound during sucking may or may not indicate a problem, but we need to see the mother. It can require further assessment. The baby may have tongue tie, but we have to look for that. Sometimes there is no problem at all, but we have to look for that if she faces any problem. So this is nipple suckling. An inadequate latch on, the mother is not satisfied, baby is also not satisfied, and there can be some complication afterwards. Again, baby's position. Last 4 points, baby's position. The baby should be turned towards the mother. There should be good skin to skin contact. The head of the baby and the body should be in one line. There should be no angulation between the body and the head. Neck, back, and buttocks should be well supported by the mother's both hands. They are very important as far as baby's position is concerned. Last 4 points of mother's position regarding correct breastfeeding technique. She can sit comfortably. She can lie down also. She should hold the breast in big C grip. She should touch the nipple to the upper lip of the baby by bringing nipple in front of nose, and that gives chance to give mouthful of breast inside the baby's mouth, so as to baby opens the mouth widely. So the negative pressure is created inside the baby's mouth. Again, last but very important point, the mother should interact with the baby while breastfeeding. Otherwise, TV pe channel chalu hai, saas bhi kabhi bahu thi, TV serial is going on, and mother is giving full attention to the TV serial. Baby is very wise. He knows that mother is not giving attention to her. So this is not at all proper thing. The mother should interact with the baby while breastfeeding. Tammy photography in Walks of Life Motherhood Project has nicely written, the warmth of her body on mine and the look on her face while feeding, it is just priceless. It makes the world stop for a while every time. So that should be the interaction between the mother and the baby. So again, what is good position and what is bad position? In first, you can see mother is looking towards the baby, a very comfortable, relaxed. In other picture, she is watching Saas Bhi Kabhi Bahu Thi, Kahani Ghar Ghar Ki, and she is feeding the baby with bottle. So first is correct picture and second is totally wrong picture. It will bring obstacle in the total journey of breastfeeding. This is again wrong picture. The baby is not turned towards the mother. There is no support and there is nipple suckling. Again, the mother is introducing her fingers just like scissor between the breast and the mother's mouth. Totally wrong. Again, what will be the complication because of wrong latching on? There can be cracked nipple. Patient will complain of there is some wound at the base of the nipple, and again she will complain of pain while breastfeeding, and somehow she will be so much afraid of, she will get afraid of breastfeeding. She will not breastfeed the baby because of pain. You can see the crack at the base of the nipple. In second picture, again nipple suckling is shown. Baby is not at all turned towards the mother. There is no skin to skin contact, and mother is totally confused what to do because she is getting pain. There can be cases of flat and inverted nipple. Some can be truly inverted. Some are like they can be protracted also. Some can be flat nipple. But you have to counsel to the mother that nipple is just gate for the exit of the milk. Main thing is areola. So even if it is flat nipple, even if it is inverted or retracted nipple, she should not worry. But she should be added in our list of high risk mother because they may need some attention. They may need some correction. They may need some techniques to improve the breastfeeding technique. So this is a syringe method. We use a retracted nipple or inverted nipple so as to pull the nipple outside. So that it is for mother satisfaction. She feels that there is a nipple. Again, attachment or latching on is very important. Just presence of nipple is not at all important. Proper latching on, what I had described previously in the first few slides regarding latching on, that is important. But syringe method can help the mother that it can pull the nipple outside. Before breastfeeding, she has to practice this exercise, breastfeed the baby. Again, in between the breastfeeding, she can practice this exercise 6 to 7 times. How to prepare the syringe is very important. You can approach to the BPNI mother support group or anybody who can teach you very nicely. So these are the steps how to use the syringe for the inverted or retracted nipple. These are the breastfeeding positions. You can see in Marathi it's written Jhula Paddhati, cradle method. Second is modified cradle method. Third is football method. You can hold, mother can hold the baby like football in case of cracked nipple. Cesarean mother can breastfeed the baby like she has hold the baby, or anesthetist has put the baby in the reverse way. Even she can turn on her side and breastfeed the baby. So fifth one is lying on lateral side. And last is football method, again used for the twin baby or multiple babies. So her time will also be saved. There will be no partiality between male and female babies. They both can be breastfed simultaneously by using football method. So how frequently, this is a common question the mother asks us during our rounds, how frequently child should be breastfed? So at least 8 to 10 times in 24 hours. This is up to 15 days. But sometimes the mother may face difficulty that baby is sleepy. She tells us that she breastfeeds for few seconds and the baby sleeps. So we should teach the mother the technique of proactive feeding, means how to wake up the baby who has slept, just taking few milliliters of breast milk. Again, mother should remember that every time baby may not cry. Rather, crying can be late signal. Baby will not accept breast milk if she cries. So mother should recognize early feeding cues. How she will come to know that the baby is hungry. Demand feeding after breastfeeding gets established, that is after 1 or 2 weeks. Till then, she has to recognize early feeding cues. But demand feeding can be given after the breastfeeding is established. How much milk per day should be given? This is again a common question, whether baby is satisfied or not. There is one statistics related to baby's age and stomach size. So it determines how much milk should be taken during each feeding. It affects how many times per day the baby should receive breast milk. It is seen that on the first day, on an average, a breast baby consumes around 30 to 40 ml per day. In the first week, around 300 to 450 ml. In first month, 750 to 1050 ml per day. And this daily intake of milk relatively remains stable up to 6 months. After 6 months, complementary food is started, so the frequency or quantity can change. So again, colostrum, you know, this is thick, dense, and almost gel-like yellow colored because of the beta carotene. But this is the first vaccine of the baby. The mothers ask us, only thoda sa hi दूध आता है, दूधच येत नाही किंवा थोडंसंच दूध आहे. So we should teach these mothers, this is colostrum, that is first vaccine of the baby. So it is thick and small in quantity, but it satisfies the baby's nutrition and the resistance and the immunity needs. Again, there are some things as far as energy is concerned. It is seen that rapid increase in milk volume parallels to newborn's increasing stomach capacity. So on day 1, around 5 to ml is the stomach capacity of the newborn. And baby requires around 40 ml of breast milk. Day 3 volume increases to 408 ml and stomach capacity near about 4 times, 27 ml. Day 5, again 705, double the day 3, stomach capacity 57 ml. Why it is important, I will tell you in the next slide. And a calorie requirement is around 67 kilocalories. This is the very important point as far as energy consumption is concerned, energy requirement is concerned. So these are the lactogenesis 1 to 3 slides. Lactogenesis 1 starts from 16 weeks of pregnancy up to the 30 to 40 hours of post-pregnancy, and up to the onset of copious milk secretion. And from there, lactogenesis 2 starts up to 2 weeks postpartum. For that, early initiation and 48 hours postpartum care postpartum advice is very important, so as to stimulate lactogenesis 1 and again lactogenesis 2. These are the hormones which are responsible for the lactogenesis 1 and 2. We did not go into detail. Then strategies to wake up the infant. What the mother should do, the infant is sleepy after taking few milliliters of milk, breast milk. Remove the blankets, remove the clothes, change the infant's diaper if soiled. Place the infant, this is very important, place the infant skin to skin. That will make the infant to go towards the breast and she will start breastfeeding. Massage the infant's back, abdomen, arms and legs. So these are the technique how to wake up the infant. What are the early feeding cues? How mother will come into know that baby is hungry? The baby will be restless. She will do rapid eye movements. They can be soft cooing or sighing sounds. Baby will make sucking movements as if she wants something. There will be sucking sounds. Again, there can be hand to mouth movements. These are very common, but every time they did not be taken into granted that baby is hungry. There are other reasons also. Crying is a late feeding cue and mother should not wait for crying, and it can interfere with effective breastfeeding because sometimes because of crying, the baby is so fussy, baby is so irritated, he or she may not accept breast milk. The question again comes to our mind, is really milk less in first few days? The same colostrum slide, it is around 30 to 90 ml. Why it is less? Because baby has extra fluids when the baby was inside the body in utero. So the extra fluid should be lost. So if large volumes of breast milk in this period is given, it can overload the baby with fluids. That's why there is decrease in weight in the initial days of postpartum, after the birth of the baby. So the question is whether that will satisfy energy requirement because the quantity is very less, 30 to 90 ml. Whether it will satisfy the energy requirement of the baby? The answer is of course no. Again, there are two questions. Which milk has more caloric value? Colostrum or mature milk? Colostrum has 65 calories per 100 ml, while mature milk has 67 calories per 100 ml. So how it will satisfy the baby's caloric requirement? Calorie requirement of the baby per day in the initial days is 100 calories per kilogram. So if the baby's weight is 3 kilogram, his requirement for the calories will be 300 calories per day. And the calories baby receive per day, how much? Colostrum is only 40 ml. So that 40 ml will supply around 25 calories per day. But requirement is 300 calories per day. So if you deduct the amount, deduct the calories from 300 minus 225, so there is a deficit of 275 calories. How the baby will gain these calories is very important again. Baby has have enough stores of glycogen in the liver, and so when they are frequently put on the breast, this glycogen store, rather this glycogen is broken down into glucose, that is called as glycogenolysis, and this glucose that meets the caloric requirement. So extra 275 calories, the needs of the baby, from 300 minus 25, 275 calories are supplied just by glycogenolysis. That shows the importance that frequent suckling is very important, otherwise baby will be deficient in calories. So blood sugar levels are directly proportional to the frequency of feeding. That's why we say the baby should be breastfed at least 8 to 10 times in 24 hours. Then only the baby will get sufficient calories. Otherwise, just colostrum caloric value is not sufficient for the baby. Bilirubin levels are inversely proportional to the frequency of feeding. More the feeding, less the bilirubin. While blood sugar will increase if there is more frequency of breastfeeding is more. Last few slides. The mother asks, is my baby getting enough milk? But there is always confused state. थोड़ा सा ही colostrum आता है, whether baby is hungry, whether hungry because of whether the baby is crying because of hunger, or something has happened. Probably the milk is not sufficient. So you have to teach the mother, if the baby breastfeeding is sufficiently established, baby passes around 6 to 8 times urine in 24 hours. But it is after establishment of breastfeeding, after 7 days or 6-7 days. But in the first hour, sometimes baby doesn't pass urine. So baby is in dilemma. Something has occurred with the baby. So you have to tell the baby that sometimes baby may not pass urine for 48 hours. But after that, at least once she should pass urine after 48 hours. Sometimes the baby passes urine on first day only. It's okay. But even if she does not pass urine on first day, the mother can wait for 48 hours. And after she starts passing urine, at least once she has to pass urine. Regarding stools, this is the formula like day 1, 1 stool, day 2, 2 times stool, day 3, 3 times stool. Again, the consistency and color changes. First day it is black, then it changes to black and green, and then to yellow. So, and with some particulate matter, because the breastfeeding is increased, baby starts taking breast milk. Regarding weight gain, this is very important because every time mother is not going to pediatrician for weight gain. So if the birth weight is 3 kg, on day 5 or day 6, there is loss of around 7 to 8% of weight because of the loss of fluid from the baby's body. But up to 15 days, the baby must achieve the birth weight. This is formula. Up to 15 days, baby must have the birth weight. After 5 months, the baby's birth weight should be double the birth weight. And after 1 year, the weight should be tripled. So this is like formula. 15 days, baby's weight should be like birth weight. 5 months, double the birth weight. 1 year, triple the birth weight. But this is in general. Every time, it's not that if the baby doesn't increase in that grams or kilograms, there's something problematic, but it's a general formula. So for myths of last part, there are some, for certain myths of breastfeeding, we have to teach the mother. Lactating mother should avoid some food stuff. We know that except cesarean mother, that is also for few till next day, we start oral fluids, third day we start soft diet. But there, nothing should be restricted. She can eat everything, each and every food stuff, because the mother-in-law always tries to give some watery substance to mother also, kheer denai. They don't give a diet as such, and the mother becomes weak. So we must educate these mothers and their mother-in-laws and mother also, give everything to the mother. Mother should strictly breastfeed in sitting position. They feel that mother should sit down in the chair or sit in the chair, then only she can breastfeed. We all know that she can breastfeed in lying down position also. Any position, whatever comfortable is for the mother and the baby, that is ideal for the pair. In Marathi, we say Sukhasan. Whatever breastfeeding position, the mother can breastfeed very properly, very calm and quietly and comfortably, and the baby is also calm and quiet, accepting breast milk properly. That is Sukhasan for the pair. Feed on both sides during one breastfeed. This is also a wrong technique. We have to teach mother that each breast contains foremilk and hindmilk. Foremilk is sugar and water, hindmilk fats. So the weight will increase if hindmilk also given. Foremilk only sufficient to pass urine. But the baby should receive both type of milks. So there will be enough passage of urine. Again, the weight will increase. And once one side breast is emptied, then only switch out to another breast. If the baby is hungry, he can accept the other breast milk. If he is not hungry, he will leave the breast. So leaving the breast on his own is very important. Foremilk should be fed, hindmilk should be fed. If the baby's hunger is satisfied, the baby will leave the breast. So leaving the breast is important. And second time, the other breast should be given. Again, the other breast should be emptied. Unless and until breast gets emptied completely, there will be no milk production. So this is very important. Otherwise, breast will remain engorged and there will be a negative feedback mechanism. And again, the local receptors will say there should not be any damage or injury to the breast tissue. So the mother will, the mechanism will stop producing milk. So we have to teach mother, empty the breast first, one-sided breast first, then switch out to another breast. Emptying of the breast is very important. If baby cries excessively, it implies that breast milk is insufficient. This is also a myth in the minds of mothers. There are other reasons of cry. Sometimes baby has done some past urine, or sometimes she has passed stools. Baby wants to just go outside with the mother. These are the other reasons for cry. So every time cry doesn't indicate that baby is hungry or baby breast milk is insufficient. I will just tell a few things regarding expression of breast milk, because again there is one separate lecture on breast pump. Sometimes to initiate, to maintain and to increase the breast milk production, expression of milk is tried, especially to stimulate lactogenesis 2, to prevent the engorgement, to have milk available for the caregiver to breastfeed the baby, to maintain or increase milk production in case of twin baby or multiple babies, to elicit the milk ejection reflex. Sometimes breast milk need to be transferred to neonate or sometimes to the sleepy baby afterwards. So sometimes there can be chances like the more effective collection of colostrum, especially for preterm babies or in the first 3 days of postpartum. It can be beneficial for the baby who has been kept in NICU. So there are certain indications why we have to teach the mothers how to express the milk. Sometimes the baby is in the NICU. If the baby doesn't breastfeed, if the mother doesn't breastfeed the baby, though there cannot be any expression of colostrum. That is very important for the further milk production. And colostrum is, it's very immunologically very good one. So we
Hello,
need
Dr. Alka. Can we?
Yes, last two
wind
slides.
up?
Yes.
Yeah.
So
We
there
have
will
two
be
more
another
speakers.
lecture for mechanical expression of breast milk. So friends, breastfeeding is instinctive and physiological. We know. Look at the face of the mother, satisfied mother and satisfied child. How comfortable the breastfeeding is. So breastfeeding was best, is the best, will remain the best for infant feeding. We should never forget breastfeeding. So all of we will take place today. Will promote, will protect and support breastfeeding. And again, even if the corona atmosphere is there, whether we should breastfeed or not, yesterday there was nice discussion. We must breastfeed a baby, taking all the precautions if needed, since it is natural, instinctive and physiological. It's a mother's, not only mother's right, but it's a child's birthright as well. So getting breastfeeding correct from the start is crucial to long-term breastfeeding success. Life is about doing the best we can with what we are given in the spirit of love. So we as healthcare providers,
I think we can stop here, Alka.
And properly breastfeed the baby and give proper advice.
Thank you,
very
Dr.
much
Alka.
for patient listening.
Yeah, thank you. I think all the speakers have done a very good job, and I think it was very nice hearing all of you, and very good information we received from all the speakers. Now, is it the time for the question and?
No, Madam, we'll take the questions at the end because there are 2 more lectures and we can keep together. Huh?
Okay, fine.
So thank you so much, Madam.
Right.
And Parag, if he's still
Yeah, thank you, Mangala. I am here. I am listening.
Good. Thank you so much. You'll be there and you will be asking the reading the questions as well for the panel.
So after the next session, we will take it.
Yes.
Right.
So we'll start the next session.
Thank you.
Thank you so much.
Yeah, thank you, Parag.
Thank you.
Thank
you, Sneha.
Yeah, I'm back. Join the
Yes,
session
welcome,
again.
Sneha, again. So we are starting now the second session. And now this is again important session and we have 2 expert people chairing the session. So I invite Dr. P.K. Shah sir and Dr. Sharad Agarkedkar sir. So they are there both. So Dr. P.K. Shah sir, he is a professor and HOD of the GS Medical College and KM Hospital, Mumbai. Past President FOGSI and past Dean Indian College of Medical Ultrasound, past President of IH, past President MOGS, past President Association of Full-Time Teachers, KM. My God, so many presidential posts. Past Chairman of the Imaging Science Committee, past Chairman of ICOG West Zone, Joint Secretary Images, and Fellow of the Start International USA. And he has been, talking nationally and internationally in so many conferences. So now I invite first Dr. Shah sir, and he can introduce the next speaker, that is Dr. Prashant Gangal.
Hello, Dr. Sharath. I would like to say hello to Dr. Sharath.
Thank you, Dr. Mangala. It's a great pleasure to start the second session. And the first speaker is Dr. Prashant Gangal, our good friend. And it's a pleasure to introduce him. He is a practicing pediatrician in Mumbai for last 29 years. Has been a mother support and training coordinator of BPNI Maharashtra since 1995. And also co-coordinator of Mother Support Task Force Working Group of WABA since 2003 and a lactation consultant since 2009. He has been attached to 12 private institutions in Mumbai as lactation consultant. He's also undergone training in lactation management by Dr. Felicity Savage, I think a big name in the field. He was also instrumental in establishing the first mother support group in India in 1995. He also a lot of publication, is a speaker at LLLI conference at San Francisco and Chicago. And he spoke on breast crawl. I'm sure we all know about this particular thing in 2014 and on WHO growth charts 2016 at Gold Lactation Online. He is going to talk to us on a very important subject, and that is breast-friendly, baby-friendly hospital initiative. I'm sure you must have heard of this. We started this initiative way back in late 90s with Professor and Head Dr. Armida Fernandez at Sion Hospital. And I'm sure Prashant will remember that we did a lot of work on BFHI and even mother-friendly hospital initiative. So I have a great pleasure in having Dr. Prashant Gangal. You can start your talk now, Prashant.
Yes. Hello. Am I audible?
Yes.
Yeah, you're audible.
Okay. I'll just do it full screen. Full screen. Okay. Thanks, Dr. Shah, for that introduction. Today's topic is Baby Friendly Hospital Initiative. And at the outset, I would like to thank FOGSI for having invited me over here. I'm also thankful to Dr. Mangalavani, President BPNI Maharashtra, giving me this opportunity. I would like to extend my discussion on this first slide. Baby Friendly Hospital Initiative. What is Baby Friendly Hospital Initiative? BFHI refers to the maternity practices, how maternity homes support breastfeeding and help mothers to breastfeed successfully. But there is a fallacy in the statement. It refers to maternity homes. Maternity home cannot be hospital. Till about 100 years back, mothers used to deliver at home. And hospital is a place where patients go. And mothers are not patients. So I think in future, WHO should change this particular definition and make it converted to maternity home. Next, at the bottom, you can see a certificate. Dr. Shah, if you remember, at the initial stage of the program, this was a very beautiful certificate which was given to hospital, which was baby friendly, and it was issued by Government of India. Now that certificate is no more available. We issue certificate from BPNI Maharashtra side. But yes, we would like to borrow that certificate from the government. My presentation has been prepared from two presentations made by lactation consultant LC Dipti Shah. She will be speaking after me. And so her name appears over there. Now in both our names, there is a degree at the bottom called IBCLC, International Board Certified Lactation Consultant. I'm very proud to say that our president and our senior faculty, Dr. Alka Kute, who spoke over here, they both are lactation consultants. We brought this exam to India in 2009 and 2010, and 28 faculty from BPNI Maharashtra passed this exam. And I'm very proud to say that HODs of neonatology of KM, Sion and Nair and many pediatricians from the medical colleges appeared in the second round and they passed the exam. And after that, our maternity, our lactation consultants and counselors were posted in those particular hospitals and maternity services, and the head of the departments and the professors could support them very well. So the faculty becoming IBCLC is important so that everybody talks at the same wavelength. In India, there is a custom that anything starts with recalling Lord Ganesha. And here is a picture, a very beautiful picture where Bala Ganesh is breastfeeding and Mata Parvati can be seen. So I invoke Lord Ganesha for blessings for this particular presentation, also for this conference. Protecting, promoting and supporting breastfeeding, the special role of maternity services, a joint WHO statement 1989. The start of Baby Friendly Hospital Initiative. Beautiful document, 40 pages, available on the net. Please download it and read it. The summary of this particular book, which appears at the start, is 10 steps to successful breastfeeding. As I said initially, a maternity service which supports breastfeeding and helps the mother to breastfeed success is baby friendly. People talk about breastfeeding a lot, about its advantages and everything. There is a Abhanga by Tukaram which says, Bole taisa chale tachi vandavi paule. It's very great to talk about breastfeeding, but just lip service is not enough. Converting it into practices which help the mother, and that is where we lack. And that is where the problem is. So BFHI talks, this book talks about how your knowledge can be converted into.
You are not audible, sir.
Prashant, we cannot hear you.
Sir, we lost your voice. But he's unmuted actually. So.
Hello?
Mangala, can you call him up and tell him?
Yes.
I don't know whether he receives our
10
messages
steps.
or not.
Yes, he's there.
Some problem with internet, local problem.
Are you back, Dr. Prashant?
Prashant, can you hear us? He has been muted, I think.
Is my screen visible there?
Yes, sir.
It is visible.
Okay, fine. So why maternity homes are important? Frequent and prolonged contact starting from antenatal period, delivery, post-delivery. So maternity services can affect the mother's thoughts and actions, knowledge, attitudes and practices. It is a contact during a critical period, very sensitive period. Obstetric problems and interventions mostly negatively affect breastfeeding. Oxytocin is responsible for delivery as well as for breastfeeding. So good birthing experience will give rise to good breastfeeding experience also. I'm not able to change the slide to the next slide.
So use down arrow.
Yes, yeah. I went to the next slide. Breastfeeding is known as fourth stage of labor. In the longer sense, up to 1 to 2 weeks, till the time breastfeeding is established, the fourth stage of labor continues. And till that time, it is the responsibility of the maternity homes, including obstetricians, pediatrician staff, to ensure that mother goes through this particular stage of establishment very well. What starts well and continues well ends well. So initiation in maternity homes is very important. Most breastfeeding problems occurred in postnatal ward stay, and therefore empowering maternity homes to take care of that is important. It's very important to tell the staff that what they do with the mothers has great impact on neonatal, infant and under 5 mortality. So all these points are important. In the baby friendly workshop, when we talk to the staff members, we tell them that you are like mothers to the patient, and just like after year, mothers don't get tired of helping you at night, during the day, any time of the week. Similarly, nursing staff and others should help the mothers because they have a mothering role for a mother. First 7 days in a maternity home if cesarean, and first 3 days in delivery is normal, are very important. What starts well, it's like a 50-over match. If you do score well in first 10 overs, then obviously the match is won. Just like Kaluvitharna and Jayasuriya used to win matches for Sri Lanka. Then how we come into picture over here? We have been involved, Dr. P.K. Shah would remember, in assessments of maternity homes in Mumbai and Maharashtra in 1993. Dr. R.K. Anand, Dr. Kumta, Dr. Hathi, Dr. Armeda Fernandez, all these stalwarts are involved. And I was with them at that particular time because I just finished my MD in 1990 and attending workshop with Dr. Felicity Savage and then starting with this work. We collaborated with UNICEF Maharashtra. UNICEF Maharashtra has been there with us. We have continued, though the assessment processes nationally probably have gone into freezer. We have continued in Maharashtra and around to assess hospitals. We assessed twice the hospitals which were maternity services which are associated with mother support group. And those hospitals where we can assessed, and we tried that the practices match with that of guidelines. I'm proud to say that presently in 85 maternity services in Mumbai, small and big, and Pune, our mother support group is attached over there, almost covering all institutional hospitals. 3 years back, we trained and assessed 27 MCGM, Municipal Corporation Maternity Homes in Mumbai, in a period of just 1 month, using about 20 faculty members. Last 2 years, we have been engaged with Government of Maharashtra for BFHI and MA assessment. I would talk about MA assessment later on. And that we covered about 37 NICU, SNCU associated maternity homes. That covers most of the maternity hospitals in Maharashtra and civil hospitals also. And now what we plan is to train 100 BFHI commandos. We have 65 IBCLCs, we have about 35 counselors, we have a number of 100. And all these 100 will be further interested in the task of becoming BFHI commandos. We have a large force where the same people go and assess the hospitals and they are at same wavelength. This is my picture when I read the document in 1989. So let us see what I gathered out of that particular document of WHO and UNICEF. I will go to step number 6 first because I feel that is very important. And the first step I would assess if I go to a maternity home, I would be talking practical stuff, that what answers we get from maternity home. Do not provide breastfeeding newborns any food or fluids other than breast milk, unless medically indicated. In assessment, it is important to find out how many deliveries per month, how many normal, how many cesarean, what percent of normal babies get supplements in forms of, say, formula or milk or glucose water or just plain water also, and how many of cesarean get these particular supplements. And you'll be surprised to know that 100% of cesarean deliveries in most hospitals receive some supplements. More than 50% of normal babies receive some supplements. So that's a very shocking figure. And I have come to a conclusion that obstetricians, pediatricians, and nursing staff have lost confidence that normal full-term babies can survive on just breast milk and breastfeeding. So we need to regain this particular confidence. Two more things we practically do when we go. We ask ayabais, and ayabais, what do you feed the babies? And they will take us into the pantry and show us the formulas and show us the milk and the katoris or bottles which are used for feeding. Then we also walk to the pharmacy to find out that how many tins have been prescribed in last 1 month, and you will get to know. Upstairs, the residents and the faculty might say, no, 100% exclusive breastfeeding. But going into details, you will be able to know that what is going on. So it is important that what Dr. Alka-Gute discussed, early feeding cues and how to wake up a sleepy baby, that has to be taught to every nursing staff and mother, and that can be ensured. The next important step I will go back is step number 3, pre-delivery counseling. हाँ, आपके यहाँ होता है, मदर्स को बताते हैं आप ब्रेस्ट फीडिंग के बारे में? हाँ, बताते हैं. कभी किधर बताते हैं? ओपीडी में बताते हैं. कितने पेशेंट रहते हैं ओपीडी में? 100 पेशेंट रहते हैं. कितना समय रहता है? 2 घंटा रहता है. तो हर एक मदर के लिए कितना समय रहता है? नहीं, 2 मिनट में बता देते हैं ब्रेस्ट फीडिंग के लिए. That is not antenatal counseling. Antenatal counseling means you have to have formatted lecture, formatted discussion for the mothers at least once during the entire period. We have developed a format for pre-delivery counseling, and it's very important that pre-delivery counseling occurs because that is what trains and prepares the mothers for breastfeeding. As simple a things as what clothes the mother is planning to use. Otherwise, hospital provides a gown which it just has one button and mother doesn't know where to feed from. Or the mothers come with fancy gowns and we have to tell them that this is just petticoat and shirt will be a very good dress, or just 2-piece night suit if you can call it. So antenatal counseling is very important. Then I come to point number 4. Point number 4 has already been discussed. So you go to the labor room. Now we are trying to change the concept of labor room where we feel it is a very drab name. We are now calling it Naujat Shishu Agaman Kaksha or Baby Welcome Room. The physical and the mental structure of the labor room or the Naujat Shishu Agaman Kaksha has to be changed with a new name. The staff has to be supportive. Other than giving oxytocin in the bottle, if they try to increase oxytocin of the mother by talking to her like mother, mausi, kaki, then probably she will have better oxytocin, internal oxytocin, and she will deliver properly and the delivery might be fast. We might be able to avoid the cesarean sections. So what percent of babies? The answers we get, yes, we initiate breastfeeding in 1 hour. When? 59 minutes and 59 seconds, we take the baby to the breast and the baby feeds. That is not what the baby friendly house is trying to tell you. The skin to skin contact starting in 5 minutes of delivery is also important. Quite a few hospitals will initiate feeding when the mother is shifted out. But that means 1.5 hours has gone. So no hospital after shifting can feed within 1 hour. So you have to go into those details when you're assessing the hospital. The next point important is 5, support mothers to initiate and maintain breastfeeding and manage common difficulties. The first question I ask is, what is the cause of cracked nipples? And 99% of the times I get an answer, poor hygiene. Mother has not maintained the breast hygiene properly. So then you ask her about positioning techniques. Every mother should be able to answer, not every mother, at least sample set of mothers should be able to answer that at least large part of the area should be given and that are in the baby's mouth, and that has been taught to me by the nurses. Yeah, as far as expression technique is concerned, usually there are no protocols. Every nurse tries to, follow some different protocol, and most of the times this expression is painful. So having a proper expression protocol is also important. Point number 5, support mothers to initiate and maintain breastfeeding and manage common difficulties. Yeah, so every patient should know at least the basics of positioning, attachment, and expression. In case the baby gets shifted to premature unit, we must go to the NICU and ask that what percent of babies get discharged on exclusive breastfeeding or breast milk. Quite a few nursing homes, NICUs, don't have beds for the mothers outside. They may have 100 beds, no beds for the mothers. That's amazing. In fact, we have been talking to the government and asking them that to make a rule that if you have 6 NICU beds, you should have 6 beds for the mothers. Is the expression of mother's milk started soon after delivery, and does it occur 8 times in 24 hours if the baby is shifted? Most of the times, the expression is started after the baby needs breast milk. Now that may be after 3 days or 5 days, so that also needs correction. And whether mothers are allowed in the NICU, how far is the NICU from the postnatal ward? All these questions become very crucial. Is the milk transferred? There is a special technique of colostrum collection. In first 3 days, colostrum cannot be collected in the katori. So it can be collected in a syringe and transported to the NICU. So we need to assess the NICU also, that what goes about breastfeeding over there. Do they give trophic feeding? So all these questions are very important. While giving skin to skin contact, it was discussed yesterday that babies should be given mask. Now there was a good number of phone calls to me and WhatsApp discussion, and pediatricians, especially Dr. Sushma Malik, who is the HOD of pediatrics, she told me that no mask to the babies till 2 years of age, because they're smaller airways and they can get smothered. So I would like to point out that no mask for the babies, and that is very important. Now let me go quickly over the next other steps. Step 1 has changed very drastically. Before that, step 1 and 2 are critical management procedures. Now this was introduced in 2018. Step 3 to 10 are key clinical practices. 1A, IMS code has to be followed. The IMS Act has to be followed by body, mind, and spirit. No programs sponsored, no help, direct or indirect, from formula companies at all. One nursing home we went in Raipur, everything was so nice. In the end, we told them, just show us the literature on BFH, what you give to the mothers. And out came the files which were supplied by one of the formula companies. So you have to, one of the HODs said, no, when I'm in this particular institute, I follow IMS Act. When I'm outside, yes, sometimes I attend the formula company meetings. So it should not happen just because you have come to certify the institute, that outside the behavior can be anything. Second point is, have a written breastfeeding policy that is communicated. Most of the times it would be there, but staff should know that this is what is called policy. Otherwise, they don't know what is policy. And 1C states, establish ongoing monitoring and database management systems which are not in place right now. Exclusive breastfeeding rate during the entire admission, exclusive breastfeeding rate at discharge, and initiation rates. The government is very keen to collect these rates from maternity homes. And if your rates are good in USA, I'm told that the hospital is given a grant if these rates are good. So we must start monitoring these particular rates, whatever the small maternity home this may be. Now, 1, 2, 3, 4, we have discussed 2. Ensure that staff has sufficient knowledge and competence and skills. Previously, we used to talk before 2018 about 18-hour workshop. But that 18-hour workshop is not what we want now. We want the staff to have skills, different skills. Does she know about feeding cue? Does she know how to wake up a sleepy baby? And all these particular points are important. 3, 4 we already discussed. 5 we have discussed. 6 we have discussed. Point number 7. Enable mothers and their infants to remain together and to practice rooming in 24 hours a day. This just about rooming in, but in India, what we practice is bedding in, and which is good. Co-sleeping is fine. No mother who is in a proper sense and who is not on drugs has ever slept over her baby. What deaths we hear of are SIDS deaths, and co-sleeping, in India, should be promoted. In institutional private hospitals, we have seen beds, which are attached to mother's beds, and at the same level, that is also pretty okay. Point number 8, support mothers to recognize and respond to early feeding cues, which is also a new thing from 2009. Teaching mother how to identify feeding cues is important. Crying is a late sign, and that is not good. And one very dangerous sign is that babies tend to go into more sleep. The biggest fear which maternity homes, obstetricians, and pediatricians have is about hypoglycemia. Yeah, PCNA says that a normal full-term boy will never go into hypoglycemia unless there is polycythemia, sepsis, or some other problem. Point number 9, counsel mothers on the use and risk of feeding bottles, teats and pacifiers. Yes, the talk of bottle and has come over here, but we should tell them about the dangers and see to it that counsel her in such a way, at least in India, that the bottles are not used. The feeding directly by katori also is good enough. Anything is required. And point number 10, coordinate discharge so that parents and their infants have timely access to ongoing support and care. This is lacking. In UK, they have got a very good system. After discharge, the mothers go to the chemist for weight. That weight is told back to the doctor. By 14th day, the babies normally lose weight after by about day 3 or 4, 7 to 8%. They should start regaining weight and should cross birth weight latest by 14 days. And it's the responsibility of maternity homes to ensure that. Day 3, day 7, day 14, and day 28 weight should be taken. We can devise apps where mothers feed into the app and doctors say, this baby has gone beyond the weight we have 14. So green. This baby has not gained, so red, so call him back. So we need to start using some apps. No follow-up in most of the hospitals. Babies get weighed at birth. They never get weighed at the discharge. And even if they get weighed, nurse never interprets what percent the baby has lost, and nobody keeps track of them. Next follow-up is straight at 1.5 months, which is bad, or somewhere 15 days. Nobody really tracks them. So we need to have lactation OPDs where we have mother support counselors sitting. The baby goes from there first, then goes to the doctor, and the feedback and discussion occurs between the two, and the high-risk babies are picked up. I'm sure that the neonatal mortality will come down if this is followed. 10 years after 19, the baby, I will again come back to Baby Friendly Hospital Initiative. 1989, the document which I showed you got published. 1990 or 92, WHO and NSA came up with BFHI literature and BFHI guidelines. 1998, almost 10 years into the program, they got this book out, Evidence for the 10 Steps to Successful Breastfeeding. Excellent book. You must read it. The evidences are still being used at various places. Changes in 2009, skin-to-skin contact was introduced into the initiation definition. Continue first contact till breastfeeding is complete. That is what was told. Initiation, which people used to talk about half an hour, got changed to 1 hour, because many babies, if kept for breast crawl, will probably take more than half. Some babies may take more than half an hour. Breast crawl video is there. We helped to create breastcrawl.org website in 2007, created a video. I'm sure many of you have seen that. So you must use this video in the OPD to teach the mothers how to start breastfeeding. Then Q-based feeding was initiated. That is also for 2009 change. HIV as a part of BFHI. I'm sure now COVID-19 also will come as a part of BFHI soon in next 1 year or so. And BFHI assessment may not occur in person. They may occur like teleconference like this or video conference like this. Baby-friendly NICD community clinics. When we assessed with government of Maharashtra, the maternity homes, we did MA assessment. So we assessed 10 points. We did not just assess for BFHI. We also assessed for Navjat Shishu Agaman Kaksha. We also assessed for baby-friendly NICU. We also tested for antenatal OPD, where how the antenatal OPD is going, and various forms were created for that. Not only that, we also went to the community and found out whether there were community sessions for breastfeeding. We also found how community advocacies were going on. We also talked about complementary feeding in 4D immunization clinics. We don't have time right now to discuss, but if you go on to BPNI Maharashtra website, bpnimaharashtra.org, all these points are discussed. Now, last few slides. Process of making a hospital baby friendly is fixed. First, the self-assessment point is filled. I'm also proud to say that BPNI Maharashtra has come out with some simple documents. What WHO and NSA produced was extensive forms which we bring in India. Nobody will go for assessments. So we have a single one-page assessment. So the assessment form, self-assessment was filled. Most of the time hospitals will say we are doing good. Then you study the forms, talk to them, go for the first visit, take a workshop for health stop. This workshop is also training, also COI, because the staff members in the form of teaching, they come out with practices which we otherwise would ask. They would say everything goody because they are programmed that when you go for assessment. Then you go for interviews with mothers, nurses, and doctors. Take around, see what different things are put up on the board. Whether any posters put up given by formula company, how many formulas you see. Walk into the pantry and see for bottles. And also check the written material which is given to the mothers. Whether there is a weight taken at discharge. Whether somebody calculates the percentages. What advice is given. Somebody can give a MD thesis of collecting files of pediatricians and maternity home, and what different advices are given in that metropolitan city like Mumbai, and you'll be amazed to know that in this world, some people still talk about 4 months of breastfeeding, and people talk about 1 year is enough, and people talk about different things, which you will be amazed at. Then you fill up the form, take 2 copies, keep one for yourself, suggest changes, and give the certificate one for copy back to the maternity home. You are not going for inspection like a hound over there. You are going there to help them to become baby friendly, suggest changes, help them to make changes, and at the same time give certificate of commitment to them, because maternity homes need something to show that yes, we want to make breastfeeding better. So certificate of commitment is a temporary certificate. If once they say that we have made all the changes, go for the second visits, interview mothers and staff again. If you feel that in body, mind, and spirit, the maternity home has changed, then give them the final certificate. And the last slide, it is not just about BFH or MA assessments. Mother's absolute affection. You have to decorate it with multiple things so that the whole picture comes out good. Mother support group, which we developed in 1995, that is also required to support, because pediatricians, obstetricians, and nurses don't have time to help the mothers to breastfeed successfully. We need somebody else, and that is what government has to realize. An orthopedic hospital needs a physiotherapist. You can't think of orthopedic hospital without a physiotherapist. Similarly, a maternity service needs a lactation counselor, needs a mother support group. Then we thought about the community. Once after discharge, the babies go into the hands of Maleshwari Bai, or what we call traditional massage woman. So in 2001-2, we trained 500 massage women in Mumbai, so that mothers get discharged after mothers get support after discharge. And you won't believe, the Maleshwari Bai is at 60 years or 70 years of age. Amazing. They could recollect things. We certified them. We took their exam. We took their Viva. Then we came out with Shishu Poshan app, which is available on Android for community support, to teach the community. So you must download community Shishu Poshan app. And ultimately, we have recently launched our website, bpnimaharashtra.org. Can I just show a picture of that? Just screenshot. That would be my last slide.
Go ahead.
Yeah, share screen. I have 1 minute. Let me check it is there. Yeah, this website picture I will show you. So all of you can go to this particular website. I will scroll. Are you able to see?
Yes.
I'll go down to see how the way. There's a picture of Dr. Mangalavani, who has given president's message, what we do in short. Then there is our services, breastfeeding help. We have got a search app over there. You give the area, give the name, give the hospital, and you will know which help is available. And the phone numbers and email addresses given. You can directly ring from the app, from the area. Trainings offered. We have multiple trainings, a spectrum of trainings. What trainings we offer is there, and there are hospital visits in Mumbai and Pune, where our mother support with what day they go. So we have search engines placed over there. Then we have BPNI program highlights, breast crawl, Hirkani-Kaksh, 4D clinic, Navjat Shishu Agaman Kaksh, and Shishu Poshan app. You can get details over there. And if you have activities, past activities, upcoming activities, and activity photographs. Dr. Shah, if you go to the activity photographs, you'll find a 1990 photograph of Dr. Felicity Savage, young Dr. Kumta, Dr. Hathi, Dr. Anand, and so you'll enjoy seeing 50 photographs, the timeline of BPNI Maharashtra for last 30 years.
Wow.
Then we have got resources for mothers, which you can give to the mothers. Quiz is there, FAQ is there, and childcare buy books you can buy directly or online, not available now because of COVID. And you have got testimonials from various people. And then you have got Hall of Honor, Dr. Hathi, Dr. Kumta, Dr. Armida Fernandez. You can see those pictures rotating over there. So Dr. Kumta, and we have membership. So if you are interested in our work and want to meet more people over there, you can become member over here and log in, and also join into members area where additional resources are kept. And donate if you think that this site is worth it donating. Thank you so much. Thanks for a patient hearing. And that was my last slide. Thank you so much. If you want to become baby friendly, you can approach us, at least in Maharashtra, and hope we will be able to send a team for you. And right now there is no government or UNICEF support. So of course the maternity homes will be charged whatever is our standard protocol. Thank you so much.
Thank you so much, Prashant, for a fantastic talk. I'm reminded of those days in late 90s, and I'm sure with you around, things would come up, and I'm sure you made some of the gynecologists take interest in baby-friendly hospital initiative, and I'm sure you'll get some calls from them.
Yes.
So, thank you so much.
Thank you.
And I invite Dr. Agarkedkar to introduce the next speaker, Dr. Dipti Shah. We'll take up the questions last.
Yes. Yes. So I also invite Dr. Sharad Agarkedkar, sir, and he is a professor. Can you hear me?
Yes.
So he is a professor and HOD DY Patil Medical College and Hospital in Pune. And he has done fellowship also in pulmonology. And he is past president of the IAP, and also he is a past president of IMA, and he has done lot of research, and socially also he is very active for the street children, for the children of the prostitutes and Anganwadis, and he's been awarded as a best teacher in 2006. And I'm proud to say that there is so much awareness of breastfeeding. In March, myself and Dr. Prashant Gangal has visited the DY Patil Medical College for this BFHI assessment. So I request Dr. Agarkerkar sir to introduce the next speaker, that is Deepti Shah.
Thank you very much, Mangalavani, for inviting me on this prestigious talk. And it gives me immense pleasure to introduce Dr. Deepti Shah. She is a food technologist from Mumbai. After doing her graduation in food technology from Premlila Vittaldas Polytechnic, she did DBM from Indian Merchant Chamber. So she joined the Mother Support Group to BPNI in Maharashtra in 2000. She cleared her certified IYCN level 1 in 2008, level 2 in 2010, and she is IBCLC in 2010. She is attached to various nursing homes like Lakshmi Nursing Home and Raj Nursing Home, and she has been associated with hospitals like Nair Hospital, then Bhagwati Hospital, and Cloud9 Hospital. She has worked with WABA Malaysia. She has and she has received the prestigious NB Kumta Award for Professional Excellence in 2016. She has got several publications to her credit, and she has done editorial work for the BPNI. I invite Deepti Shah to talk on the technology and devices for assisting breastfeeding. Deepti Shah.
Yeah. Thank you, sir, for introducing me. First of all, I will share my screen. Yeah, everyone can see my screen?
Yes.
Okay. So first of all, good evening, everyone. And thank you, Mani Madam and all organizing team for introducing me in this webinar. And first of all, I will like to tell you that I am not a doctor. I am just a lactation consultant. So initially I was a mother, then I became a lactation counselor. In last 10 years, I'm now a lactation consultant. I think so I'm the only one in the speaker group that I'm a non-doctor. And I would, because of this, my organization, I would like to thank my BPNI organization, all sir and madam like Dr. Prashant Gangal, Dr. Sanjay Prabhu sir, Vani madam, and Sushma Malik madam, you know, to teach me and to become a lactation consultant. And special thanks to my sir, Dr. Gangal, because he created this mother support group leader. And then now we have a 50 mother support group leader, and approximately we are covering more than 50,000 mother every year for the, and we are helping 50,000 mothers approximately every year in breastfeeding management. So my topic is devices and accessories that makes the breastfeeding easier. So first question, is it really required to use any devices for breastfeeding? You can see in the picture. So I have mentioned no. If the mother and the baby both are doing well, we should not use any devices. You can see in the picture, mother and the baby both looks happy. Whether it is an urban mother or a rural mother or an Indian mother or a foreigner, everyone is happy. So when everyone is happy, then we should not use any such devices. But yes, sometimes temporary intervention is essential. In this picture, you can see this mother looks very stressed. The baby is crying. Baby have some problem in the cleft. So when it is essential, this temporary intervention is very necessary. So today's topic I am going to cover nipple shield, nipple cooler, breast pump, Haberman feeder or a special need feeder, supplemental nursing system, and the finger feeder. First, we'll talk about the nipple shield. So when the question comes for the nipple shield, always people think we should not use nipple shield because the baby will get used to it. Yes, as I told you, these all things are the temporary. So when we prescribe a nipple shield, we also need to tell the mother after a few days, you need to try directly on the breast. And generally, the baby gets attached to the breast without shield after 10-15 days. So now when to use this nipple shield? When the baby has some latching issue due to the nipple problem, like the mother have a short nipple or a flat nipple or an inverted nipple, yes, we can use the nipple shield. When the baby is living intermittently, the latch is not constant, you can use the nipple shield. When the mother is facing problem or a pain while feeding due to the sore nipple or a crack, yes, she can use the nipple shield. Now, these are the types of different nipple shield. I have shown you in the photographs 2 cross marks. So we should not use such type of nipple shield. We have to use silicone nipple shield. So when we prescribe a nipple shield, it's our duty to teach the mother how to use this nipple shield. Because generally what happens now, we will just write it down. You should buy a silicone nipple shield. Then it's our duty to teach the mother how to apply the nipple shield and whether the baby is latching well with the nipple shield or not latching well with the nipple shield. You can see in the picture, one is correct latch and one is the poor latch. So if the baby is going to latch with the poor latch, obviously the problem is not going to resolve. Now there are advantage and disadvantage of using the nipple shield. The baby can, can the baby to the breast who is otherwise not at all. It helps with the maternal sense of accomplishment. Mother feel more confident. It can compensate for the immature feeding behavior if the suck is not constant. With the nipple shield, the baby may feed proper and then baby will start sucking also. If the mother have a pain or a sore nipple, yes, she can get little relief. Now the disadvantage of this nipple shield is the feeding can be prolonged because if the baby is not latching well with the nipple shield, latching only on the tip of the nipple, the latch will be constant and the baby will continue to feed for more than 1 hour. So that will be a prolonged feeding. Affect the nipple stimulation because now the baby is not latching directly on the breast. There is some obstruction. So it can affect the stimulation. Inadequate weight gain. As I told you earlier, if we will not observe how the baby is latching on the breast, baby might lose weight also. So when we prescribe a nipple shield, it's our duty to teach the mother. Second thing, we need to tell the mother how to sterilize this nipple shield, and the follow-up is also very important. So when we give any such devices, after 3 to 4 days, we need to check now whether the baby is started gaining weight or not gaining weight. So these things will help you. Second device is the nipple puller. So Dr. Kuthe madam showed on the slide this syringe method. So I have put 2 things, syringe and the nipple puller. So in the past and even in the now also the people are using this syringe for inverting the nipple, to protrude the nipple out, especially for the inverted nipple. So it helps, but it pains a lot. So first day the mother will use, but then second day when you go, the mother will always tell you it's very painful. I can't feed my baby because it's paining a lot. Because why will this happen? Most of the time people use a stennimal syringe. The the mouth is so narrow that when you put on the nipple, the base of the nipple or the nipple will be so big that it will be very difficult to pull the nipple out and it pains a lot. So nipple puller is little better version. You can see the flange. The flange size is little big in the nipple puller. So when you put the nipple puller, the nipple will come out, and as soon as the nipple will be protrude, you can put directly baby on the breast. So in those cases, you can save the use of nipple shield also. Here the one fallacy is, when the mother will start producing milk after day 3 or day 4, and she will start using this nipple puller, the milk will come in this nipple puller and she will try to feed that milk with that milk also. So you should not, you have to guide the mother. She has to throw this milk out. She can't feed this milk. Third thing is the expressing the breast milk. So we always tell the mother hand expression is the best expression. Even I believe that hand expression is the best. But sometimes hand expression is really very tedious. So you can always teach the mother that how to use the pump because, when to use the pump now. So when the baby and the mother is separated from each other, suppose the baby shifted to NICU, say for about 10 days or 15 days. And if we tell the mother, you use the hand for expressing the milk, so it is a very tedious job because she has to express at least 8 to 10 times in 24 hours. So when we allow the mother to use the pump, maybe she will express the milk better way and she can get more milk. So when the baby is separated, that time you can use the pump. When the baby is not at all latching, so instead of giving the formula milk, you can teach the mother how to use the pump. She can at least express the milk and she can feed the child. It also stimulates the breast, so increases the milk production. In the induced lactation and relactation, yes, this breast pump, especially the hospital grade breast pump, helps a lot. Empty the breasts that are too full. It also maintains the milk production, and for donation purpose also she can use the breast pump. Now, mother don't know which pump, which mother has to buy the which pump. So there are 3 types of pumps available: manual pump, battery operated pump, and the electric pump. So if she's going to use only once in a while, these manual pumps are okay. Battery operated pumps are not very effective. And the electric pump. Now I'll tell you about the electric pump. So there are pumps which are available for the personal use also and the hospital use also. So when we talk about the personal use, so only single mother is going to use for her itself. So that is a single pumping or a double pumping. If she has one baby and the baby shifted to NICU or for her home purpose also, the single pumping is fine. But if she has a twins and if she is affording, she can use the double pump because it helps a lot. Because simultaneously she can express the milk here, she can save her time also. And this hospital grade pump, yes, this pump we can use for the multiple mothers. Here she has to, the kit she need to change. She can't use, or a hospital can't use the same kit for all the mothers. The kit is different. That kit she needs to change it. Now, these hospital grade pumps are also important for relactation and induced lactation protocol. When we consider the features of this pump, we should know the control or a vacuum and the control for the vacuum and the cycle, let down and the expression phase. It should be a closed system barrier to protect from bacteria and viruses. Flange should be very much fitted. If the flange size is not proper, it's going to hurt, or maybe she will not get the result. Warranty is also important, and the portability is also important. Now the next devices is a Haberman feeder or a special need feeder. Now you can see in this picture, this baby have a cleft lip as well as the cleft palate. Now only cleft lip, you don't have to use this instrument. So if the baby have only the cleft lip, she can, hold the teacup hold. Teacup hold means like she can use her thumb and the first finger, lift her breast tissue, and she can block that nasal passage. Once the baby will create the suction, she will be able to latch. But if the baby has a cleft lip along and the cleft palate, yes, this Haberman feeder works better. Now, features of this feeder is it has a one-way valve. It prevents the air from entering the state. It controls the milk flow easily, and it has a 3 different flow: small, medium, and the large. So, depending upon the baby's capacity, we can always rotate that bottle. I'm going to show you the video, but not now. After the session will over, I will just share the screen and I'll show you this video. So I must thank to Nair Hospital and Dr. Sushma Malik and the pediatric department and neonatology department of Nair Hospital for sharing this video. I will share you later on. Now the next device is the supplemental nursing system. You can see in this picture, the baby is latching with a tube and mother has put some bottle around her neck. So this device works, no mechanical, no electricity, nothing required. It just works on the gravity basis. You can see this 2 thin tubes. So either mother can use both the tubes or only one single tube also she can use. If she don't want to use 2 tubes, she can always block the first tube and she can feed only with the second tube. Now here in this bottle, she can use the expressed milk. If expressed milk is not available, she can use the formula milk. And now the baby is latching with 1 tube. So she can, put the sticking plaster or a tape to sustain the tube. And now the baby is latching on the breast. So every time when the baby latches, she gets something from the breast. So in this case, at least the baby will suck at least 15 to 20 minutes. And every 8 to 10 times in 24 hours, if the baby will suck 15 to 20 minutes, automatically her supply will increase. So there are lots of videos available on YouTube. I can't share you right now. I was thinking to share one video, but because of this, the consent problem, so I don't want to use that video. So you can always go to YouTube and check how to use the supplemental nursing system. This system we can use for the adopted baby and for a relactation, or if the mother have a low milk supply. So rather than feeding with the Vati spoon, she can always use this instrument. If this instrument is not possible because it's little expensive, every mother can't afford this instrument, she can use a simple Vati and infant feeding tube. one end of the infant feeding tube, she can put it in the baby's mouth, and other hand she can put it in the vati, or a syringe also she can use, and the baby can suck directly from that. Now this is a finger feeder. Finger feeder is a similar thing like a SNS, but only thing you have to put that tube in the little finger, and then you have to gently insert the little finger in the baby's mouth, junction between the soft palate and the hard palate, and gently, you have to stimulate it. So once the baby will start sucking, she will get something from that tube or that container. Here you can always use expressed milk or a formula milk, anything, whatever is easy. And then once the baby will start sucking on the finger, then you can put directly baby on the breast and the baby will start sucking better way. Soft feeding cup. Now, after a discharge, after the NICU discharge, if the premature baby, and we tell the mother after breastfeeding, you need to give the expressed breast milk. And then we tell them, don't use bottle, you have to use a vati spoon or a palada. So mother always scared to feed with that palada because they have a fear, it will hurt my baby. So these are the soft feeding cups also available. So we need to teach the mother how to use this soft feeding cup and how to feed with that, or a simple steel katori is also fine. So thank you for this kind attention. I would like to share my video. Just a minute. So you can see how the mother is holding the baby. Okay, so when you are using this feeder, you have to hold the baby in an upright position. And then depending upon the baby's requirement, you can always change the size, like small, medium, or a large size. Yeah, so finally, I would like to tell you that whenever we prescribe any devices, we need to teach the mother first thing, how to use this device. Second thing, we need to, tell the mother the sterilization is very, very important for all the devices. And we need to teach the mother how many minutes, how many times we need to sterilize. And the follow-up is must, because when we prescribe any devices, so maybe in front of you, the mother may do fine, but then later on after the discharge, maybe she will not be able to handle it. So when you take a follow-up, so once the baby started gaining weight, that means she is using properly. Thank you so much.
Thank you, Dipti, for the excellent presentation. And it was very practical and useful for all of us.
Thank you, persons. I think we need to take now some questions. So, yes, you can go ahead and take some questions.
Madam, I have some comment on Dipti Shah's lecture. So can I make a small comment?
Okay.
Hello.
Yes.
Yeah. As far as the device, it is sure that devices are necessary. Secondly, if at all the lactation consultant or counselor is herself selling the devices, there's always a chance of conflict of interest. So that conflict of interest has to be taken care of, and all the possible options have to be given. Otherwise, the devices will be given to mothers who actually don't need them. Thank you.
Yeah, madam.
Can we take the questions now?
Go ahead. I just like to read one comment from here, Dr. Jagruti Sangvi. I have 100% commitment to feeding in the golden hour for all my patients and exclusive breastfeeding for all the mothers. I agree that required training of hospital staff and mothers to be an encouragement of the obstetricians who have shared their pregnancy journey. So I'm so happy somebody is so committed and they are doing 100% initiation within 1 hour. So it is not impossible practically if one wants to. Yeah, madam.
Hello. There are few questions. Can we take?
Yes.
So I think Dr. Alka can take this.
Yes.
There is a question: when to wake up a sleeping baby, and what should be the time interval between the interval, like to feed the baby?
Hello.
Yes. Yeah.
Yes.
When to wake up sleeping baby? Like for feeding time interval.
Yeah, but video is not on actually from your side. Video is not on from your side.
No, it's on. It's on. We can see her.
Okay, okay.
We can see you also, Alka.
Okay. The
Yeah.
question was how to wake up the sleepy child. Actually, I have given the few 3-4 things.
When to wake up? Yeah. You have given those cues. Yeah.
Yeah. Take out the blankets. Give clicks on the sole of the baby. Also take out the blankets.
No. Their question is when. If the baby is sleeping to feed, when to wake up?
Actually, what happens if the baby is taken for breast milk? Only initial few drops the baby accepts that. Then she goes to sleep. Mother feels that I have started breastfeeding just now, but baby has not taken anything inside. So in that case, if we think that the baby is not repeatedly sleeping, so to maintain that lactation or to continue the lactation, we can make the baby awaken by all these techniques.
Can I add, madam?
I think.
Can I add? Yeah. Okay. We have to ensure that in first 1 to 2 weeks, a feeding frequency of at least 10 times is maintained. That means a mother has to try and feed the baby every 1 to 2 hours. If the baby is wrapped up, the baby tends to sleep. So babies need to be woken up and feeding has to be attended every 1 to 2 hours to achieve a final frequency of about 10. And I would recommend that all maternities should have something, an alarm going off every 2 hours where mothers try to wake up and feed the babies. So to maintain that frequency, that appropriate 1 to 2 hour duration has to be maintained.
I think that was the intention for the question. Thank you, Dr. Gangal.
Yeah, thank you. Thank you. The next question is, the babies, sometimes they cry and they don't even calm down even after breastfeeding. So how can the mother be counseled or helped for that?
Actually, this also I have answered in my slide. There are many reasons for crying. Not only that baby is hungry. So sometimes she has passed stools or she has passed urine. Sometimes the baby wants to go with the mother like that, go around. So depending upon, sometimes there can be gastric colic as well. So if all these things are done, still the baby is crying. We have to see whether there is feeding cues or baby is hungry, satisfied or not. Then only we can, the mother should be taught to help to attend the OPD or pediatrician's help.
There is a myth in the community
and in preterm baby, yeah.
There is a myth in the community that babies should be fed only after crying. That myth has to be broken. Babies have to be fed as soon as they show intention to feed. If that is not followed, then the babies cry. We don't want babies to cry. If the babies don't cry, the question of outside milk doesn't come in. And presuming that hunger is always the cause of crying, don't allow the babies to cry. Feed when they show the feeding cues.
Okay, now how to treat the retracted nipple during the antenatal period? What should be done? That's another question.
Actually, antenatal period is just for screening, to note down in your list that certain mother can require your help, but nothing to be told as such to the patient because that can decrease her confidence. But we have to make the list of such mother. They may require our help postpartum. Suppose everything is good, proper latching on is there, baby is accepting breast milk properly, and all the things what we have seen throughout our lectures, then no need to treat the patient for that inverted retracted nipple. If we think that maybe mother is making issue of that, there is no proper latching on, a baby is not accepting breast milk properly, then just now Dipti has shown nipple puller, or we can try for syringe also, but nowadays we go for nipple puller. So she has to be taught how to use that so that the nipple is pulled outside. Though there is a nipple access is not required for attachment, there is some fear in her mind that because of that nipple or because of that retracted nipple, she is not able to breastfeed. So we should teach all these things and tell her, counselor, that areola inside the baby's mouth is more important than the presence of nipple.
So, madam, can I make one comment? So the main message is during antenatal prepare, that breast preparation is not necessary, because that is what is the common thing happens, and that is what the obstetricians, they think that they have to get the massage of the breast or cooling of the nipples, even if they see the nipple is flat or inverted. Automatically, at the end of the pregnancy or during labor or postpartum period, there are physiological changes in that breast. And once baby starts proper latching under the proper guidance, usually there is not a problem. But if we tell mother antenatally that there is a problem, her confidence goes further down, and then there can be further issues.
I think that was a very good information because, when we examine the breast, we do find, and, sometimes we find that there is a dermatitis or they come with pruritus around the nipples during pregnancy. So, and then after the delivery, they find really difficulty, then they develop cracked nipples and all that. So how to tackle that problem during antenatal period?
Actually, they should be told that just during their bath, whatever water, hot water or cold water, whatever they are taking, that is sufficient. No need to apply soap water especially to the breast. Just cleaning during taking bath is sufficient. If there are certain signs of fungal infection or some dermatitis, then she should take the help of skin specialist. But nothing to be applied as such during bath, like for example soap water, because that can dry the skin and that can act as a needles for cracked nipple.
And when to start the breastfeeding in preterm babies is the another question.
Dr. Prashant Gagal, you want to answer? It can be immediately breastfed.
Yeah. Usually what you would find that if you talk about late prematures, about say about 36, 37 week old baby, they are ready for direct breastfeeding. Only thing they may get pretty tired while breastfeeding. So mother has to be patient and she has to be told that particular way. Between 1.55 to 2 kg when they are just about 34 weeks, they may take some time to settle down, about 24 hours. But still, once they start showing feeding cues, even earlier than that, giving kangaroo care, and you can see the cues would come out. And there the baby can be fed with care where somebody is supervising the first few initial feeds. At 32 weeks, the baby sucking and swallowing coordination comes. So babies between 32 and 34 weeks, they may be initially, you can try feeding them on little empty breasts so that babies doesn't get choked up with the flow. Try with katori spoon initially, but if there's so good fair sucking movements, try feeding at the breast once you know that they are not choking with on empty breast. And before 32 weeks, feeding directly may be not very easy. So those initially we can give trophic feed to the babies. That means 1 or 2 or 3 ml of feed every 2 to 3 hours or 4 hours, where it prepares the intestines.
Yeah.
And it prepares the intestines and allows them to grow. And then gradually you go by practically what you see when your babies, keep the baby at the breast, keep the baby near the nipple, and what is the baby's response to the spoon or katori at the lips. And gradually, once the initial problems settle down, respiratory problems and other things, then maybe you can try. Some of these babies, of course, would need feeding by infant feeding tube. And once the baby settles with infant feeding tube, maybe you can trace the suckling and swallowing coordination. Again, feeding on absolutely empty breast here is important, checking it out. So it all goes by experience. You cannot make book rules, but it's standard, the way you can decide.
There is another question, I think, where somebody is asking that there is sometimes a lot of milk secretion even during the antenatal period or the around nearing delivery time. Okay. And some patients will come with engorgement antenatally.
Actually, we have seen cases of milk coming out of the nipple, but not cases of engorgement as such. We know lactogenesis 1 starts from 16 weeks of pregnancy up to the 24 to 48 hours postpartum. Sometimes patients do come to us, there is secretion from the nipple or from the breast. But we should educate the mothers not to squeeze out, especially in bad obstetric history, though patients having bad obstetric history, because that squeezing the milk can stimulate the pitocin, oxytocin secretion that can lead to preterm or premature labor. Instead, we should tell them, take a bath, and whatever comes out, let it come out automatically. No need to squeeze as such. Because in some countries where the mother does not give history of any bad obstetric history, miscarriage, preterm, premature labor, they have started collecting colostrum. This colostrum can be used postpartum after delivery if needed to the baby. The baby is admitted in ICU or if the mother is sick, having pregnancy-induced hypertension, eclampsia patient. But that is not practiced in India as such, as per my knowledge. Prashant can highlight this on this. But tell the mother that no need to squeeze the breast as such, because that can stimulate the uterine contraction.
Another question is when they're feeding, there is even a secretion coming out from the other breast, and the mother always feels that it is getting wasted. So what is the remedy for that then?
This is because
if there is any way to collect it?
We can collect, as I told before this also, we can collect it. But she should be told that don't get shame or that something is coming out of the breast, because this is natural under the action of hormone. many hormones play in to take out this or for the secretion, but no need to take out the secretion as such. Take a bath and whatever cleanliness or whatever her feeling is there, that secretion for the time being it will get washed off, but no need to squeeze breast as such.
Mothers get very uncomfortable when the other breast starts, throwing out milk, and we have to address that discomfort. And mother is not Jagdamba; she'll hold the baby. In the other hand, she'll hold a katori and collect that milk. So what we normally tell them, just flick the nipple, slight painful stimulus to the other nipple, and nipple would that particular breast would stop making the milk. It is very good idea for working mothers. If they are in the office, they remember the baby, they suddenly can start, having lactation. Because of oxytocin reflex. So you can just fold her hands and with both the elbows press on both the nipples, and the nipple flow and the milk flow would stop. That's a very practical tip for the mothers.
Okay. I think that was a really very good information. I think Dr. Parag, Dr. Shaha, I think, sir, if from your side, if you have any questions, you can go ahead, please. The other panel chairpersons. I think I would like to really thank
one comment that many hospitals, they give this welcome hampers, and which has also formula in it, and which is sponsored by the formula company, which again violates the IMS Act. So how to go about it?
Actually, till now, pediatricians, even gynec people, they were not aware about the IMS Act. So in many maternity homes, we see the hampers, they are bringing some formulas also, and some challenges or motivation like things for the staff also. So better we should inform civil surgeon or MOH of our district hospital. There are many organizations like BPNI, State BPNI, Central BPNI, Akash, and again IYC, Human Being Bank Association of India. If they are informed about this, the action can be taken. But there needs to be awareness amongst us also, amongst doctors, that there is a violation of IMS Act. We can inform the civil surgeon or district authority, MOH of our district, so that they can go for further action. But we must inform, because nobody informs. So that's why it is going on continuously.
No dinner comes free. So if you get something free, try to find out who is sponsoring it, from where it is coming. If you talk for a lecture, who is the organization, go and find out their donors. And please don't attend if there is any conflict of interest. That's the best solution, including stem cell companies or anything else.
That is very important.
Now, one more is breast milk rejection syndrome.
I think Dr. P.K. Shah wants to say something.
Yeah.
Sir, please unmute yourself. Please unmute yourself.
There are two things I would like to say. One is what Dr. Prashant said about Naujat Shishu Agman Paksh. I think that is one thing we can start doing from tomorrow onwards. That looks very impressive. And I think that is one message that each and every gynecologist must take from Dr. Prashant. And number two, very important, is how to improve initiation of breastfeeding in 1 hour. We are at 41%, and we should be minimum 80 to 90%. I think all of us need to put our heads, see that we address this issue very seriously, and maybe when we meet next, we will have.
Dr. P.K. Shah, sir, when our training was going, training was going on, Dr. Prashant Gangal and our team had suggested government to organize competition on Navjat Shishu Agaman Kaksha in every August breastfeeding week. So whatever, whichever district has good best Navjat Shishu Agaman Kaksha, they should be awarded during breastfeeding week. So at least that will inspire others to keep that tidy and well-looking Navjat Shishu Agaman Kaksha. So a lot of oxytocin will be stimulated, and cesarean section rate can be minimized, can be reduced rather.
Very good. But it should not come from a pediatrician or neonatologist. I think we obstetricians.
Yes, we have important roles.
Very big way.
Yes, sir.
The place where the new citizen arrives should be the best room in the entire district and the entire city. That is the concept.
What about breast milk rejection? Breast milk rejection.
Yeah, there is nothing. Breast milk rejection and breast rejection and mother rejection are almost taken synonymously. The commonest is nursing strike. So a baby who is breastfeeding well at the breast suddenly goes on a strike, just like workers go on a strike. And that may be because the mother has started spending less time with the baby. That is the commonest cause. We have to, or is giving less skin to skin contact. So in that case, the mother has to be patient most of these strikes would get over by day 7 or 8. So just keep on giving skin to skin contact, spend more time with the baby, try to feed the baby when the baby is, almost sleepy, so that a baby doesn't recognize that. Try to change the place, try to withdraw attention of the baby by sitting on a jhula or sitting on a gym ball. So these are, and express milk and keep on feeding the baby. So these are the few measures we use, and most of babies would give away the strike. Babies always love the mothers, and mothers also love the babies.
I think rarely we have to keep in mind PABC, pregnancy associated breast cancer.
Yeah, I think Dr. Kuthe will be a better person to answer that question.
Yeah, I think pregnancy associated breast cancer, no, sometimes that could be the one of the rarest reason, because we do find now breast cancer during pregnancy also, and the mothers who are treated, or during a postnatal period also, we are now finding it. So that is one of the reason for a breast milk rejection. It's not very common, as you said.
Very rare, very rare.
Yeah.
Every engorgement looking like thing or every lumpy breast is not necessarily because of milk. So that we have to keep at the back of the mind.
Yes. Tomorrow we are going to discuss this case of inflammatory breast cancer, pregnancy associated breast carcinoma. So I think we'll have more details.
I think Dr. Sneha, all the delegates are very happy with the deliberations, and I tell you, I myself am very happy. And I think this webinar is the best thing that which is reaching to so many people. Otherwise, in conferences, when the breastfeeding session starts, people just get up and go away, like go for a tea or coffee, and you don't find. But I think म्हणजे याच्या माध्यमातून हे इतक्या लोकांपर्यंत पोहोचतं ही खूप मोठी गोष्ट आहे, फार मोठी गोष्ट आहे. And I really would like to congratulate for this initiative. And during this COVID time it started, but I think it should be a continuous thing, because many people won't have attended. You can go even society wise and see to it that the message reaches to more and more people, because as Dr. Mangala said, if you look at the economy, we are you look at the economy as well as the healthier population. I must congratulate and thank everybody who has participated in this.
I think Dr. P.K. Shah sir wants to say something.
I must congratulate Dr. Sneha and Dr. Mangala for having this fabulous thing, because I think in COVID time, nobody wants to know about breast and breastfeeding. But looking at the response and the way the webinars are going on yesterday, today, it was fabulous. And I really thank you for involving me in this particular webinar. Thank you very much and all the best.
I saw one important question from the audience. Somebody is asking that sometimes baby accepts breast milk from one side and refuses breastfeeding on another side. It happens sometimes. Simple tact, we have to make the baby full. So suppose the baby is fed on right side and baby doesn't accept left side. So just take the baby like this back. So we make the baby full, like if baby feels that same breast she has taken inside the mouth, but both breasts can be given to the baby's mouth. So it happens sometimes. Some patients do complain that the baby accept milk from one breast only. For this patient, we can teach this technique, taking the baby back to another breast without changing the angle of the baby. The same angle, we can take the baby towards the second breast.
Also look for other problems, like say baby has ear otitis on one side, or baby has fractured rib, or baby has sternocleidomastoid tumor. Then the baby would not like to feed on that side. So also look for problems, why the baby is not feeding from a particular side.
And the torticollis also.
There was a very interesting question by one of the persons saying that does the mother have legal right to refuse breastfeeding?
Legal.
I would like to say, no, a very interesting question, I think. And I would like to say that at present, there is no law that can punish a mother for not breastfeeding her child. But it is a right of each and every neonate to have a breast milk and to be breastfed. I think this is something very simple. Such ladies need proper counseling. And I think their minds have to change. So that when you have to tell them what are the advantages of breastfeeding, etc. There is nothing legal about it.
Our International Lactation Consultant Association, one of the first goals for a lactation consultant is support the breastfeeding goals of the mother. That breastfeeding goal may be full feeding, breastfeeding goal may be half feeding, no feeding. So as a lactation consultant, But in India, I think with
No
you know,
such
the mothers being influenced by so many other people and inability to take decisions,
Social.
we'll have to probably go into more details before allowing this kind of counseling to go through a supportive breastfeeding. Why we need to find why she's come to that decision, and maybe that will solve the problem.
Because it is baby's right as well to take the breast milk. So both rights are important.
I think Dr. Sneha, you have to tell them that all these presentations will be available on ICOG website, and many people are asking about IMS.
Yes.
And
Please
it's
tell them as
available on the YouTube as well, madam. So they can just watch anytime on the YouTube as well.
Actually, all these sessions, there's a live streaming on YouTube as well. And there are many participants watching on YouTube as well. So at the outset, I would like to thank all of you for being rather...
Make madam wants to say something.
Yeah, of course. Madam, please. I can't see her.
Wait,
video is off.
Are you there, madam? Mandakini, madam?
She's muted herself. I think you call her.
Yeah, she's there.
She'll have to switch on her video as well as unmute her.
Definitely, very interesting sessions, very focused, dedicated session, I would say. As obstetricians, we should not be so superficial about breastfeeding. Everyone cannot be lactation consultant, and maybe at smaller places you don't get the services of lactation consultant. What I believe that we have to know this subject thoroughly, and we have to practice it day to day. So we must, all obstetricians, thank all of you in fact for this session. And as committee chairperson, I'm in fact very happy. Being a very hardcore obstetrician, I'm very much interested in this, and I carry out these sessions very frequently. Even when I was not breast committee chairperson, I conduct this breast feeding week even through JC's, Rotary, Lions, right? Almost 27 years in Yavatmal, and as a district 3030, I used to organize this, and for this, I'm so thankful to all these organizations. They are supporting this issue and making awareness about breastfeeding in the general public as well. And from this session, I'm sure that obstetrician must have been inspired from all of you, knowing the depth of the session, how you should initiate. I'm very sure every time we tell them that you must initiate, even for my every talk, I'm telling them that the moment you cut the cord, even when I was explaining delayed cord cutting, I used to tell them that the moment you cut the cord, you just leave the baby to abdomen, the baby crawls. But nobody believes in this. And I'm sure people who do this, if they keep sharing repeatedly, obstetrician must follow this practice and get the results.
Please see the video of breast call.
I'm thankful to all of you, and I request Dr. Mandakini ma'am to say something about this.
Yeah, so thank you very much, Sneha, for a very, very wonderful session. It was very, initially I was there, in between I had some meeting, I had to go. But very important thing for the participants is, tomorrow we are going to give them the questions, MCQ. It will be in the middle of the, it may be in the, after 2 sessions or 3 sessions. And after that, they have to solve those MCQ and send it back on the email. And once they clear that MCQ, then the ICOG certificate will be mailed to their official email address. So be ready for tomorrow's MCQ solving. And Sneha, what are the session tomorrow, so that after 2 sessions we can give, or after 1 session we can give them the MCQ. Mr. Vishal and Jaktap will be ready with the MCQs tomorrow. I think you have given them the MCQ also.
Yes, I have already forwarded, and the link is also ready, which they are going to mail to participants. We are all set for that.
Sure,
yes,
no problem. Important message for tomorrow, and let us hope we will have a very wonderful concluding session tomorrow. And I'm getting a lot of calls that it was from Ludhiana, Chandigarh, from far away places in India. Getting a lot of calls that this was the best ICOG certification plus breastfeeding course. So thank you very much. Thank you, Dr. P.K. Shah, Sheila, Dr. Alka, Uday, and Dr. Mangala, and everyone. So let us meet tomorrow. So goodbye.
Thank you, madam. Thank you, madam.
See you. Thank you.
Thank you. Thank you, all the speakers, Dr.
Thank you,
Gangal, Dr.
Sneha.
Sudhir
Thank you,
Mishra.
Mangala.
Yeah, thank you,
Sneha,
Pandit
Mangala.
all.
sir.
Thank you.
Yes, thank you all.
Thank you.
Thank you so much. See you all.